also call it the tympanic branch of glossopharyngeal. Tympanic branch of glossopharyngeal nerve. Right? But we also said that any plexus, not only tympanic plexus, when you look at any of the plexuses are not made up of only one nerve. Thin plate which is separating the middle cranial fossa and the middle ear. अगर ये plate ना हो, तो that means your middle ear will be in direct contact with the meninges. What is above it? Above this will be the meninges. There will be dura mater, there will be arachnoid mater, and there will be brain. So let's say if I draw something above this, so above that, what will be there? There will be the dura mater. Above that will be the arachnoid mater, and above that there will be brain. Let's say these are the gyri and sulci. Just drawing it roughly here, so that is basically part of the brain here. So tegmen tympani is a thin plate of the bone which is separating this middle ear, everything below is middle ear, to above what? To this part. It is separating it to from the meninges. This is, let's say D is for the dura mater. This blue here, it is for the arachnoid mater. And as you know that pia mater is adherent to the brain, so this is brain here. Basically the temporal lobe is present in this region. Right? So that's all about the roof. Roof means zyada kuch nahi hai. That roof of the middle ear is formed by the tegmen tympani. Kuch points which I also request you to please keep writing them separately. I'll come back to this diagram. So we started with the roof here. Tegmen tympani. So just remember the word, that's enough. Tegmen tympani, which is a part of what bone? It's a part of temporal bone. It's a part of temporal bone which separates middle ear cavity from the middle cranial fossa, or you can say from the brain. Temporal lobe of the brain. Right? So guys, this is the roof here. Okay. अब बात करते हैं floor की. Floor, the one that you're looking at here, this obviously the one which is below here is the floor. Floor of the middle ear, it is called the jugular wall. Why we call it a jugular wall? Because the superior bulb of internal jugular vein is present just below that. Superior bulb of internal jugular vein. It's always good to draw these things, guys. Let us say this here is the internal jugular vein. In fact, I should draw it like this, that it's a superior bulb. So this here is the superior bulb of internal jugular vein. When the internal jugular vein is formed, it formed like a bulb actually. But the bulb head is present exactly below the floor of the middle ear. So that's the superior bulb of the internal jugular vein. And that is the reason, the floor is also called as the jugular wall. Floor is also called as jugular wall because it is in relation to the internal jugular vein, or you can say the bulb of, or more precisely the superior bulb of internal jugular vein. One nerve will also come out from the floor. I'll tell you what is that, but let's wait for it. Okay. So I hope you understood that. This is a simple part. Roof and the floor. Roof is by tegmen tympani, and floor is by the jugular wall. When I will show you the real-time picture, you will be able to understand everything in here. I want you to पहले एक बार थोड़ा memorize कर लो कि what structures are present in which wall. Then we will look into the atlas images, and your understanding will definitely improve about how these structures are placed. Okay. Coming to the anterior wall, that's an important part. Anterior wall, the one which is in front of the middle ear, is also called as a carotid wall. Now this is something we have already discussed when we are talking about the facial nerve also. First of all, it is in relation to the internal carotid artery. The anterior wall of middle ear is in relation to the internal carotid artery, and make sure it is only the lower part, not the upper part. So this here is the internal carotid artery. Internal carotid artery. This is the anterior wall I'm talking about, right? And that's the lower part. And upper part of the anterior wall is having two very, very important openings. Now the opening that you see in the upper part here, is basically transmitting a muscle inside the middle ear, and that muscle is the tensor tympani. Tensor tympani, जो anterior wall से muscle enter करता है, the muscle which enters from the anterior wall, that muscle is tensor tympani. If I may just draw this muscle here, let us say the muscle comes in here. That's a muscle coming in here, and that's how it is entering into the middle ear. थोड़ा सा तो curve कर लेना, it will be more helpful to understand in the later part. So this is the muscle that is tensor tympani, and obviously this opening is the opening for the, or you can say it is a canal for tensor tympani. Tensor tympani or tensor tympani, whatever we call it. Remember, tensor muscles are supplied by the mandibular nerve, so that's the same tensor tympani we're talking about, and it is present on the anterior wall. Although how it is reaching the lateral wall, we will discuss that, but that is there in the anterior wall. Below that, there is another important opening present on the anterior wall, and that is the opening for the eustachian tube. Auditory tube or eustachian tube, right? That's what we have been talking about. That is the eustachian tube or auditory tube. So this here is called the tubal opening. This is called as the tubal opening. Tubal opening. Obviously, this tubal opening is for the eustachian tube. We know that eustachian tube, where it is opening in the nasopharynx, right? Behind the inferior nasal concha. So that eustachian tube opening, that is a medial opening, and it is a lateral opening, which is in the anterior wall of middle ear. So when you think of the anterior wall of middle ear, there are four important things. One still is left. I'll tell you what is that. One is that if you start from above, there is a canal for tensor tympani muscle through which that muscle will enter into the middle ear, anterior wall. That's how I'm pointing my finger also. Then there is an opening of the eustachian tube. Obviously, when there is a tube which is connecting the nasopharynx and ear, so that tube is going backward, will go to the anterior wall of the middle ear. So it is opening on the anterior wall of middle ear, and the remaining lower part of the anterior wall is basically having internal carotid artery. And we have a sympathetic plexus around the internal carotid artery, which nerve will also go inside. We will talk about that. We will come to that in a while. Okay. Now, there's another important thing, guys. This canal that you're looking at, which is the canal for tensor tympani, a small bony slab will also be seen extending in the form of this canal only. There's a bony slab which is seen. Let me draw it in this way. And this bony slab here, let me put a hash sign here. If you have space, you can do that. Otherwise, you can write the name also. Guys, the hash which I drew, that bony extension is called as the processus. That is called as a processus cochleariformis. Processus cochleariformis. But a processus cochleariformis is a bony projection which is basically the same canal which is transmitting the tensor tympani muscle toward the middle ear. And what is the function of this bony projection? This is a bony projection. This is a bony projection. And the function of this bony projection is that it acts as a pulley. It acts as a pulley for tensor tympani. Tensor tympani muscle, it needs to work on what? Tympanic membrane. That's a word. That's why the name is tensor tympani. Now look at me, please. All of you just pay attention to me. Let me turn my head to one side. Now this is my anterior wall of middle. Let us say this is my anterior wall of middle ear. Now muscle entered from the anterior wall, the tensor tympani muscle. But it has to stretch what? Tympanic membrane. Now let me turn my face again. So imagine the tensor tympani muscle was coming from the anterior wall, but it has to stretch what? Tympanic membrane. And tympanic membrane is found on which wall? Lateral wall. And last discussion, we said that there is a handle of the malleus which is attached to the tympanic membrane. So let us say this, my stylus here is the handle of the malleus. So this tensor tympani muscle running in this direction is not useful. We have to turn this muscle in this direction and attach it to the handle of malleus. And how can one muscle or tendon be reflected or can turn toward in another direction? That is by a pulley. And that pulley is formed by a bony projection called as a processus cochlear corpus. So this is a bony projection which is basically present between these two openings, between the tubal opening and the canal for tensor tympani. Or ये tensor tympani muscle को allow करेगा to turn toward the lateral side and then attach to the handle of malleus so that it can pull it inside. And that's why tympanic membrane is something like this. Remember that umbo, that point of convexity, is because of the pull of this muscle itself. So this is all about the anterior wall. We have a canal for tensor tympani. We have a processus cochlear corpus from where the tensor tympani muscle will curl toward the lateral side. We have a tubal opening which is giving obviously which is the medial opening, or I should say it is not the medial, sorry, what is the posterior opening or the opening of the eustachian tube toward the middle ear. And the internal carotid artery is in relation to the lower part of this. And that's the reason the anterior wall is also called the carotid wall, because of internal carotid artery. So this is the anterior wall that you saw, and we also call it the carotid wall. That is also called as the carotid wall. Makes sense? Tegment tympani, jugular wall, carotid wall. So till now we have just discussed the three walls here. Now before I discuss the remaining, we have discussed three walls. We've got the medial wall, the posterior wall. Lateral thumb already discussed whether it's tympanic membrane. So before I come to the most important medial wall and the posterior wall, I need a very quick feedback, because this diagram is I wanted to just tell me that if you are able to understand this diagram here, if you are oriented at what is lateral, medial, anterior, posterior here, don't worry about how exactly these things will look like in middle ear. That I will do. That I will just show you the pictures and I will label that for you. If you understood this anterior wall, floor, and the roof, then the rest of the part is not difficult to understand in fact. See, before I go to the posterior wall, I'll tell you about this wall. There's a medial wall here. Okay, wonderful. Look at this medial wall, the one which I've highlighted here. Guys, we know that medial wall, the one which I've highlighted, inside that medial wall is internal ear. And internal ear में क्या present है? Cochlea. See? So cochlea, the first turn of the cochlea, cochlea will make a turn, उसको बोलते हैं basal turn of cochlea. The very first turn of the cochlea or the basal turn of the cochlea will produce an elevation here on this medial wall, and that elevation is called as a promontory. So this here is the elevation present on the medial wall, and this elevation which is present on the medial wall is called as a promontory. That is called as a promontory. I'll just keep writing them in short so that so PM is for the promontory, right? The three ear ossicles, malleus, incus, and stapes. We know that stapes is the one which is attached to the medial wall, and stapes is attached where? Posterior superior to the promontory, guys. This is promontory, and posterior superior यहाँ पर कहीं होगा. Posterior superior to the promontory, the foot plate of the stapes is attached, and because the shape of the foot plate of the stapes is like an oval, so this window is also called as a oval window. This is called as an oval window. I should write that in short actually. That is called as an oval window. Location is important. Posterior superior. It is posterior superior to the promontory. That is an oval window where the foot plate of the stapes will be attached here. But let's keep writing all these things here. And posterior inferior to the promontory. Posterior inferior to the promontory is another window which is called as the round window. As I said, I should not be writing all this in here. Let me just write round window. Oval window, round window. Okay, let me just quickly write about these features. फिर उसके बाद वापस आते हैं. So as we said, now we are looking at which wall? We are looking at the medial wall of middle ear. And this is the only wall on which separately a short note, a very very short note can be asked on it. Usually the short note is on the middle ear itself. लेकिन अगर आपसे पूछना चाहे, they might ask you a 2 mark kind of question or 3 mark kind of question on the medial wall. Out of all the wall, medial wall and the lateral wall, that is tympanic membrane, are the most important. Okay, medial wall pe we saw that one of the elevation is the promontory. Reason for the promontory is it is due to the basal turn of cochlea, the first turn of the cochlea. The basal turn of cochlea or the first turn of cochlea forms the promontory. That's one thing. Another thing, on the medial wall we saw that is a round window and oval window. Now, oval window was the place where the foot plate of stapes is attached. You know the location, that is posterior superior to the promontory. दोबारा बताने की जरूरत नहीं, it is posterior superior to the promontory, the oval window. And round window is the place where secondary tympanic membrane is present or attached. Look, what exactly is the secondary tympanic membrane? That is a subject of discussion in the internal ear. Just, I hope you know about it, but let me just give you a very quick feed about it. You know that cochlea is having 3 tubes inside. There's a kind of 3 tubes inside the cochlea, right? So there is a scala vestibuli, there is a scala tympani, and so what happens is when the oval window pushes the fluid inside the cochlea, that fluid will obviously through the cochlea it is pushed, and that wave which is created by this push of this oval window will come back from the apex of the cochlea and comes back toward the middle ear. Imagine the middle ear is completely bony. and it is not allowing any displacement of the fluid. So this oval window will never be able to push the fluid inside. So अगर आप एक ऐसे example दूं, if this is a tube here, you know physics more than me, right? If this tube is filled with water, completely with water or fluid, if you push this through a paddle or something, this paddle will be able to go inside and push this entire fluid and can push that if there is a flexible membrane attached at the other end, so that this membrane can get stretched and the fluid is displaced here. When this footplate of the steps or this handle comes back to its position, this membrane will get straightened here. So there's a small window which is present posterior, inferior to the promontory, which is called as oval window, and it is having a membrane present on it. It's not a bone, it is a membrane present on it, and that membrane is called as a secondary tympanic membrane. Because every time tympanic membrane vibrates, now understand this, every time tympanic membrane vibrates, all the three bones or the three ear ossicles will also vibrate. When the stapes will vibrate, it will push the oval window. When the oval window is pushed, the fluid inside the cochlea is pushed, and that displaced fluid will come back and will hit this round window, which is having a secondary tympanic membrane. So every time you see tympanic membrane is vibrating, this will also vibrate like this. Tympanic membrane vibrate from there, and this round window, also oval window and round window, of course, they will also vibrate along with it. So that is a place where the secondary tympanic membrane is present here. So basically, यहाँ से cochlea start हो रहा है, अंदर जा रहा है, और जो वापस आ रहा है, end हो रहा है, that is ending at this round window itself. Okay. Before I add more detail to this medial wall, from the floor. Now look at this floor, but from where? From the floor, but very close to medial wall. From the floor, but very close to medial wall, a nerve will enter into the middle ear and go to the promontory, and this nerve will contribute in the formation of the plexus. And I'm sure you all know about this plexus. That is a tympanic plexus, right? So that's another thing over there. That is a tympanic plexus. I'm writing TP, tympanic plexus. So if that is a tympanic plexus, so what is the nerve which is entering from the floor here? Let me just point out this one. This nerve which is entering from the floor is the tympanic branch of the glossopharyngeal nerve, also called as the Jacobson's nerve. याद है आपको? Tympanic branch of glossopharyngeal nerve or Jacobson's nerve, it enters from the floor, and today we can understand that it is entering from the floor, but from where? Close to the medial wall. Floor here, but very close to the medial wall only. So when I'm talking about this asterisk sign, it is in the jugular wall, and in the floor we also have the nerve entering through. That is a Jacobson's nerve. Jacobson's nerve, which you can also call it the tympanic branch of glossopharyngeal. Tympanic branch of glossopharyngeal nerve. Right? But we also said that any plexus, not only tympanic plexus, when you look at any of the plexuses are not made up of only one nerve. This is a parasympathetic nerve. Jacobson's nerve is a parasympathetic nerve. Sympathetic nerve comes from where? From the plexus. Obviously, where will be the plexus? Around internal carotid artery. So we do have a sympathetic plexus present around the internal carotid artery, and from this sympathetic plexus, a nerve entering through the anterior wall. Obviously, anterior wall, nerve entering through the anterior wall and also contributing to this plexus. In fact, there are two of them, not one. These two nerves, let me give it number 1 and number 2. These two nerves are called as a carotico-tympanic nerve. This number 1 and 2. These two nerves are called as superior and inferior. Superior and inferior. Carotico, because they're coming from carotid artery, carotico-tympanic nerve contributing to tympanic plexus, carotico-tympanic nerve, and these are obviously sympathetic nerves. Parasympathetic is the Jacobson's nerve, and sympathetic nerve is coming from the sympathetic plexus around the internal carotid artery. This is the sympathetic plexus, or though nerve enter from the anterior wall, obviously it goes toward the medial wall and contribute to the tympanic plexus, right? Contribute to tympanic plexus. Okay. So I hope this much is clear. There's something else in the medial. That's why they love asking questions on the medial wall, because there is more to it. What is the other thing we have on the medial wall, guys? There are two things that you see in the medial wall. One we have already discussed. In fact, we have discussed both while talking about the facial nerve. Facial nerve, guys, we know that facial nerve runs on the medial wall of middle ear and then turns and runs on the posterior wall, right? Facial nerve, अगर आप देखोगे तो facial nerve obviously will go like this and then it will turn on the posterior wall and run downward here. Facial canal. The facial canals. Prominence of the facial canal will be seen something like this. And then this facial canal will be seen running on which wall? On the posterior wall. This facial canal will be seen running on the posterior wall. As I said, there's something we already discussed, that facial nerve runs on the medial wall of middle ear and then it runs on the posterior wall of middle ear. So one of the elevation that we marked here on the medial wall is the elevation for the facial canal. Elevation for the facial canal. And above the elevation for facial canal, there is another elevation present here on the medial wall at the very corner here, at the posterior superior corner, and that is a impression for what? Lateral semicircular canal. Lateral semicircular canal. I hope you remember, we talked about this in the facial nerve, guys, that facial nerve can be injured at this level, and that injury is called at the level of lateral semicircular canal. There are 3 semicircular canal, and the lateral semicircular canal is having an impression on the medial wall of middle ear. So 2 things. I have to find out the space to label all this. This is 1. Try to label it in the upper part, because we still have to label a few things in below. So we have impression for facial canal, this is facial canal. Impression for facial canal or prominence of facial canal, and this prominence here is for the lateral semicircular canal. I'm writing SCC, lateral semicircular canal. So these are the structures that you see on the very, very important medial wall of middle ear. On the medial wall of middle ear, and most of the things you will be able to see in the diagram, in the atlas images also. You will see a promontory, which is because of the basal turn of the cochlea. You will see an oval window where posterior superior to the promontory, and that is basically the place where the footplate of the stapes is attached. Posterior inferior to the promontory is the round window. Round window is the place where the secondary tympanic membrane is attached. Then the nerves coming from the floor and coming from the anterior wall are giving the parasympathetic and sympathetic supply to form the tympanic plexus on the promontory. Posterior superiorly, this is posterior superiorly on the medial wall. Medial wall ka posterior superiorly, you have 2 impression. We have an impression that is an impression for facial canal, the facial nerve is passing through it, and then we have a lateral semicircular canal impression as well on the medial wall. So this is about the very, very important medial wall. After tympanic membrane, I would say medial wall is another potential short note question. Tympanic membrane answer remove as I already explained it to you. Now, lastly, coming to this posterior wall, guys. The posterior wall. First of all, what is the name of the posterior wall? The posterior wall is behind and it is facing toward the mastoid process and mastoid antrum. इसके पीछे हमें mastoid process होगा, mastoid air cells होंगे. So that's why this posterior wall is called as a mastoid wall. Posterior wall is called as a mastoid wall. Let's close this off. That is a mastoid wall. Two, three important features of the posterior wall that need to remember. One, you can already see that we have the facial canal running behind it. Now, in the upper part of the posterior wall, we have an opening which will allow the middle ear to connect posteriorly to what? To the mastoid antrum. And this opening is called as an adductus to mastoid antrum. Adductus is just the name for the opening. आप opening लेंगे तो भी चलेगा. Adductus to mastoid antrum. Adductus to mastoid antrum. Adductus to mastoid antrum. Then below it, there's another prominence. There's another prominence that you will see. Another prominence that you will see on the posterior wall, but again very close to medial wall. Guys, please pay attention to all these things here. There is a prominence which is present on which wall? On the medial wall, but very close to the medial wall, toward the medial side. बाहर की तरफ नहीं, अंदर की तरफ. It is close to the medial wall. This prominence is called as a pyramidal eminence. This is the pyramidal eminence. So this elevation that you're looking at right now here, this is called as the pyramidal eminence, and this pyramidal eminence basically is giving passage to the tendon of which muscle? Stapedius. So stapedius tendon. The stapedius tendon will be, and again makes sense, guys, because the stapes is attached to this oval window. So stapes is toward which wall? Stapes is toward the lateral wall or toward the medial wall? Toward the medial wall. So this pyramidal eminence, which is giving space for the passage of the the stapedius muscle, is also close to which wall? Close to the medial wall. So that's a pyramidal eminence through which the tendon of the stapedius will come out and will obviously attach to the neck of the stapes. We discussed it last time. It attaches to the neck of the stapes here. There are two muscles in the middle here. One coming from the anterior wall, one from the posterior wall. From the anterior wall is tensor tympani. It comes from the anterior wall, but it goes toward the lateral wall. The one which is coming from posterior wall is basically acting on the stapes, and stapes attached to the medial wall. So that's how these walls of the middle ear are present. Let's have a very, very quick recap on this, and then I will label some pictures with you. And after I label the pictures with you, I'll again take a small feedback that if you understood that in those images here. So guys, as I said, middle ear, although the shape of the middle ear is definitely not like this, we have an epitympanic recess is there, hypotympanic is there, and when you look at the middle ear in a real-time section, it is absolutely a different thing altogether. So when in third year we'll do the otoscopy, so you'll understand that how to identify the structures in the otoscope. At this, as an anatomical knowledge, you should be able to understand the walls of the middle ear, that which wall, what you expect to see. So as I said, the lateral wall, if you start with, is a tympanic membrane, which we have already discussed. The few things about tympanic membrane, if I revise it for you, what the pars tensa, pars flaccida, anterior posterior malleolar fold were there. There was the handle of Malleus attached, and there was umbo, the point of maximum convexity, and there was a cone of light in the anterior inferior quadrant of the tympanic membrane. If you revise that part, you must be knowing it. Anterior wall of middle ear, which is facing toward the internal carotid artery, so we call it the carotid wall. In the upper part, it is having the canal for the tensor tympani muscle, and below that we have a bony projection. It's basically the continuation of the same canal, and that is called as the processus cochleariformis, which is acting as a pulley along which the tendon of tensor tympani will turn toward the lateral side, so that it can attach to the handle of Malleus. Below that, opening for the eustachian tube is there. Below that, you can see some superior and inferior caroticotympanic, the sympathetic nerves which are entering from the anterior wall and will contribute to the tympanic plexus. Floor is called as the jugular wall because it is in relation to the superior bulb of the internal jugular vein. Roof is called as tegment tympani. It is made up of the again temporal bone only, a thin plate of temporal bone which is separating it from the meninges and from the brain. That is tegment tympani. Posterior wall, guys, posterior wall is facing toward the mastoid process, so we call it the mastoid wall. In the upper part, it is having an adductus to mastoid antrum. इसमें नीचे एक fossa incudis भी होता है. Don't have to remember that actually. There is something called as a fossa incudis. There is a small depression will be there here, which will be called as a fossa incudis. As the name suggests, fossa incudis. So this is a fossa which is allowing the incus bone to rest in it. There is a process of the incus called a short process of incus that rests in this fossa called as fossa incudis. Then we have the facial canal running posterior to it, and there is a pyramidal eminence which is present on the posterior wall but close to the medial wall. On the posterior but close to the medial wall, and that is giving passage to the tendon of the stapedius muscle. Medial wall, the most important out of these five. The promontory because of basal turn of cochlea, oval window, the footplate of the stapes attachment, round window for the secondary tympanic membrane attachment, and then we have tympanic plexus on the promontory, and on the medial wall you will see the eminence of the facial canal, and very much at the corner, at the posterior superior part of the medial wall, you also have the prominence for lateral semicircular canal. Okay, before I write about the nerve supply and the blood supply of the middle ear cavity, let me just use some pictures here and try to make you understand how the middle ear cavity will look like. Well, there's a picture we've already been discussed, guys. That is a lateral wall which we just removed, and the view is from this side, from the outside here. So we're looking at that's a medial wall here. If I just try to show you some structures here, if not all, on the medial wall, look at this elevation here. That is cochlea has just started here. That's a basal turn of the cochlea. So this is promontory. Look at this. That is promontory. Promontory ke upar, that is an oval window, and that is a round window here. That is a round window. So the fluid is pushed inside, will go all the way, and that wave will come back, and then will push this window here. That is a round window here. But as I said, everything cannot be understood on this wall here. So let's take some images which I'll label for you. But that's an interesting picture because this tells you about the posterior wall, medial wall, roof, and the floor. A lot of things can be seen in this image here. Okay, I wanted to start with the anterior wall here, guys. This here is the anterior wall, and you can see the mastoid antrum, mastoid air cells can be seen. So there is a posterior wall over your roof and each floor, and that promontory is telling you there is a medial wall here. So what you see in the anterior wall, guys? This here is the canal. For which muscle? For this muscle, and that muscle is a tensor tympanic muscle. Let me just label it neatly so that I'll share the same image with you. And this elevation, look at this bony projection coming inside. Can you see this bony projection coming inside? This is what you call as the processes cochleariformis. Processes cochleariformis. More below that, look at this opening. There is an opening for what? Eustachian tube. There is an opening for the Eustachian tube and auditory tube. So the diagram that you just drew with me, just compare it with this, guys. Does the anterior wall look like the same? That's the exact thing. Was schematic diagram. There is a more real kind of picture. So we have a canal for the tensor tympani muscle. That is the processus cochleariformis, and you can see obviously that this muscle can go like this and turn using this processus cochleariformis as a pulley. Below that, we have an opening for the auditory tube, and you can see internal carotid artery is present in the lower part here. So anterior wall may be also have the relation of the internal carotid artery, and you can see a nerve also going from this internal carotid artery, sympathetic nerve entry. They've just shown one, but yes, there are more than one. So that is all you see in which wall? In the anterior wall. Okay, floor. Two important things in the floor. First of all, look at this fossa here. This is the fossa where the internal jugular vein, the bulb of the internal jugular vein will be present. So in the floor, you will see the bulb of the internal jugular vein will be there, and the same floor is giving passage to what nerve? To the Jacobson's nerve. Jacobson's nerve. That is a tympanic branch of glossopharyngeal nerve. इसी floor से enter कर रहा है, contributing to the promontory. Okay. What else can be seen, guys? Medial wall can be seen very clearly, and all the features of the medial wall can be appreciated. Obviously, this whole thing over there is a promontory. So there is a promontory, right? Superior lateral to promontory, you can see attachment of the footplate of stapes. That is what window? That is the oval window. I'm writing OW for the oval window here. And posterior inferiorly, this here is the round window. There is a round window, right? RW, there is a round window. So oval window and round window. Posterior superiorly, posterior inferiorly to the promontory. More along the posterior wall, if you along the medial wall, you can see the facial canal. So that's a facial nerve. So facial canal can be seen. I'm trying to label it neatly so that I'll share the same image and not to label it again. And even above that, there is the elevation formed by what? Lateral semicircular canal. So guys, whatever I'm highlighting in yellow here, they are all the features of which wall? Medial wall. You're looking at the promontory, the oval window, the round window, and looking at facial canal and lateral semicircular canal also. Okay. Same picture, and we can see the features of the posterior wall also. Now look at this facial canal is continuing at the back. So again, in the posterior wall, one feature here is that we have the facial canal. I'm writing FC again here for the facial canal. Now, this is opening toward this whole thing here is the adductus to mastoid antrum, guys. Look at these openings here. These are the adductus to mastoid antrum. I'm just writing adductus here. This dark color, there is an adductus to mastoid antrum. That's how the middle ear is communicating to them, and that is on the posterior wall. You can clearly see this elevation. That elevation is what? That is a pyramidal eminence here. Pyramidal eminence. I'm writing PE for the pyramidal eminence, and you can see pyramidal eminence is giving passage to the tendon of stapedius. There is a stapedius tendon, and obviously the nerve which is supplying the stapedius can also use this pyramidal eminence to supply the muscle as well. So posterior wall canal, that's the feature that you should know, that we have adductus to mastoid antrum if you go from above downwards, and then you will see the pyramidal eminence which is giving passage to the tendon of the stapedius, also giving passage to the nerve which is supplying the stapedial muscle, and obviously facial canal is present behind. Roof में बेटा कुछ ज़्यादा है नहीं, आप देखें roof, this whole thing is roof only, and that is tegment tympani. This plate which is present above here, this is tegment tympani only. Tegment tympani. See, one thing which I'm not able to see, which should be there in the anterior wall as well as posterior wall, is the chorda tympani nerve. And why are we not able to see chorda tympani nerve here in this section? Because chorda tympani is very close to the lateral wall. Abhi lateral wall is removed from this image. Lateral wall is removed, and rest everything is to be seen here, right? So that is why the chorda tympani nerve is also not seen. Now I'm going to show you another picture in which, let me turn this entire thing, guys. Right now, look at me. You're looking at the picture in this way, that this is a lateral wall and that's a medial wall. We remove the lateral wall and you're looking at which one? The medial wall directly. Please understand, lateral wall, medial wall. We remove the lateral wall and you're looking directly to the medial wall, promontory and everything. Now imagine if I put back this lateral wall here. Understand this. If I put back this lateral wall, turn it like this, and remove the medial wall now. This was the lateral wall, this was the medial wall. If I turn it like this, so that's the lateral wall, actually turn to that side now, and I remove the medial wall, so I will be able to see the inner aspect of the lateral wall. I will be see the inner aspect, this aspect of which wall? Of the lateral wall here. So what I expect to see here, I'll be able to see the lateral wall is for tympanic membrane, so I should be able to see the umbo, I should be able to see the handle of Malleus, I should be able to see which muscle? The tensor tympani muscle attached to it, and I also will see the chorda tympani nerve which was very close to the pars flaccida. So another diagram here, and this here, I hope you understand this image. Just take 10 seconds and get an orientation, guys. You are looking at the lateral wall, this is tympanic membrane, the lateral wall, but from inside. You're looking at the lateral wall, but from the inside here. And that is why you are able to see the handle of Malleus. This is tympanic membrane. Let me just quickly label that with tympanic membrane. This is the handle of Malleus. Right? This is the one which was on the anterior wall. That what muscle is that? That is a tensor tympani muscle. And you can see the tensor tympani muscle is now reaching to the handle of Malleus and pulling it. And that's why this point will be umbo. And coming from, look at the branch of facial nerve only. That's a facial nerve, right? That's a facial nerve only. So branch of facial nerve which is entering through posterior canaliculus and then coming out from the anterior canaliculus and running in close relation to the pars flaccida part of tympanic membrane. So this nerve here is chorda tympani. The chorda tympani nerve can also be seen. But the view आपको समझना पड़ेगा. This view is of the lateral wall, but from inside. Lateral wall, but from inside. Middle ear की story है. If you have an orientation of the middle ear, you will never forget in the life. If you don't have an orientation, doesn't matter how much of the otoscope images you will see in the atlas or in the on the Google, you'll not be able to understand how exactly the things are oriented. So first have a memory of the structures, कौन सी चीज कहाँ पर है, and then with that memory, if you try to look at that, you'll be able to find out. So just to know that if you're able to understood all this here, I have taken an image from the other book also, another atlas, it's called the Thames Atlas, and let me use that atlas as a small test for you. So guys, if you understood that all the walls of the middle ear, let me use that image in which all the walls, almost all the walls are visible. Throw a slightly different scenario, the way to show it, and let's see if you are able to label it for me. There are certain things which you will label it for me. Now, this is a picture, let me first tell you, in which the lateral wall, I want all of you to focus, lateral wall, medial wall, the promontory thing, the medial wall can be seen. That is a posterior wall. This is anterior wall is removed. So in this picture, the anterior wall is removed. So you are basically seeing from the anterior side here. That's the check of your orientation here. Now I'm labeling few things here. Let me see if you could tell me that what exactly are those here. Okay. Starting with A, and precisely, look at this precisely on which I've marked there. Just don't tell me the name of the bone itself. A, B, C, D, and E. One, F. Process over there is the lateral process of the malleus. That is the lateral process of malleus. This muscle B is tensor tympani muscle. As you can see, it is attached to the handle of malleus. That is the tensor tympani. C, that is obviously the adductus to mastoidentrum. You're right. That is adductus to mastoidentrum. Wonderful. Then you have above the facial canal. This here is the opening for the prominence for the lateral semicircular canal. The C, D is lateral semicircular canal. E is obviously the Jacobson's nerve. That is the Jacobson's nerve, or you can say the tympanic branch of glossopharyngeal nerve. And if this is the Jacobson's nerve forming the tympanic plexus, now you're right. This nerve which is going out here is a lesser petrosal nerve. Wonderful. That is a lesser petrosal nerve which goes out of the middle ear. And F here obviously is the pyramidal eminence which is giving passage to the tendon of stapedius. So this is pyramidal eminence likha wo bhi theek hai, and the one who written the stapedius, that is also theek, but that is a pyramidal eminence that you're looking at. So moving on, we've discussed about the walls here, and I said just when you get a question on this, do not waste your time too much about writing about the structures present over there, because when you look at the BDC, there's so many things which are written about everything over there. So make your own answer. Don't have this bookish language over there. Write about every wall. Write down some features and draw this diagram. Obviously, the diagram which we drew here. This is a universally accepted diagram for the middle ear, and you can definitely draw this. You can definitely draw this in the exam, and you will not lose any marks at all. So to finish off this middle ear, let me just very quickly tell you about the arterial supply and the nerve supply of the middle ear as well. The arterial supply. The tympanic membrane was supplied by certain arteries. Again, those arteries will come into the picture. If you know that one of the arteries was the anterior tympanic branch. It was an anterior tympanic branch of which artery? Of maxillary artery. You can say of the first part of maxillary artery. Anterior tympanic branch of maxillary artery. It supplies the inner surface of tympanic membrane. Anything supplying the inner surface of tympanic membrane obviously is a middle ear supply, because inner surface of tympanic membrane is toward the middle ear. Then we have another branch which is again supplying the inner surface of tympanic membrane. That was a posterior tympanic branch of stylomastoid artery. And stylomastoid artery is a branch of posterior auricular. It's a branch of posterior auricular artery. Maxillary artery, posterior auricular artery, they are the branch of external carotid only. Then guys, we do have branches coming from the middle meningeal artery. You don't have to remember those names. Middle meningeal artery branches. We call them petrosal branches or superior tympanic branches, but no need for the name. Just middle meningeal artery also gives off some branches inside. Middle meningeal artery branches. We do have branches coming from the branches of ascending pharyngeal artery. Branches of ascending pharyngeal artery. Branches of ascending pharyngeal artery. And finally, we also have direct tympanic branches of internal carotid artery. Internal carotid artery also gives off some tympanic branches. That's basically the third part of the internal carotid artery. Now, what is third part of internal carotid artery? We will discuss that in the neural anatomy. So we can keep it for now. Tympanic branch of internal carotid artery. Venous drainage. Now, there are certain things that you got to remember, like venous drainage of the middle ear. The majority of the venous drainage of the middle ear, it goes into the superior petrosal sinus. Superior petrosal sinus, which should not be difficult for you to remember, because superior petrosal sinus was obviously in the upper part of petrous temporal bone, and that petrous temporal bone is contributing in the formation of the middle ear itself. So it's very, very close to the area we're discussing here. The superior petrosal. So venous drainage goes to the superior petrosal sinus, and it also goes to the pterygoid venous plexus. The same venous plexus which was between the pterygoid muscles. So into the pterygoid venous plexus as well. Honestly, not very important to remember. Lymphatic drainage. Lymphatic drainage of the middle ear. As I told you, there are no lymphatics or lymph nodes present inside the cranial cavity. So how much the deeper the structure is, the lymphatics has to come out only. So the lymphatic drainage of the middle ear also comes out into the preauricular. Remember the preauricular, the mastoid node, and retropharyngeal. Preauricular and retropharyngeal. The same with the tympanic membrane we discussed. That is preauricular lymph nodes and retropharyngeal lymph nodes. And finally, the nerve supply. The nerve supply of the middle ear. First, obviously, we saw the tympanic branch of glossopharyngeal nerve. That was a tympanic branch of glossopharyngeal nerve, which nothing but the Jacobson's nerve. Now, the tympanic branch of glossopharyngeal nerve is not only forming the tympanic plexus over there. In fact, via tympanic plexus, it is supplying the mucous membrane of the middle ear. So, mucous membrane of the middle ear, and what is there in the continuation of the middle ear is the eustachian tube, mastoidentrum. So, their mucous membrane is also supplied by the same nerve only. So this tympanic branch of glossopharyngeal nerve or Jacobson's nerve, yes, it forms the tympanic plexus, and that tympanic plexus gives off the lesser petrosal nerve. But The only function of tympanic plexus is not to give passage to the lesser petrosal nerve, but also to supply mucous membrane of what? Mucous membrane of tympanic cavity, that is middle ear cavity, of mastoid air cells, or you can say mastoid antrum, mastoid air cells or mastoid antrum, and even auditory tube, eustachian tube. If you go back and look into your notes, eustachian tube nerve supply also includes glossopharyngeal nerve. When we talk about the eustachian tube nerve supply also involved the glossopharyngeal nerve. That's the one. This was a parasympathetic one, guys. And the sympathetic nerve, we said it is by what? It is by the superior and inferior. What nerve? Carotico-tympanic nerve. Superior and inferior carotico-tympanic nerve, which I don't have to tell you again. They're coming from where? They're coming from the sympathetic plexus around the internal carotid artery. They enter from the anterior wall, and they're coming from the plexus around the internal carotid artery. So, well, that's about the middle ear cavity. Itna mushkil bhi nahi hai. Once you understand this, the orientation of the middle ear, then no matter what kind of image it is given in the book, if you have a good orientation, you will be able to identify the structures. Middle ear infection, just one clinical case I'll tell you. Middle ear infections are called as otitis media. We call them otitis media. Otitis is for the ear, itis inflammation, media, middle ear. So middle ear infections are called as otitis media. It could be acute otitis media, it could be chronic otitis media. The thing is, if there is a pus collection in the middle ear, if there is a pus collection in the middle ear, first of all, otitis media chances are more in case of adults or in case of young ones. Young people or the children, they are more prone to having a middle ear infection. And you know the reason, because the eustachian tube is not oblique, it is more or less horizontal. So if they have a horizontal type of eustachian tube, so the infection from the nasopharynx can easily reach into the middle ear. So first thing is that the otitis media, the infection of the middle ear, the inflammation of the middle ear is commonly seen in the children, very common infection in the children, the middle ear infection, and that is because of the horizontally placed eustachian tube. And let's say if somebody is having a eustachian tube infection, it is drained by incising the tympanic membrane. You know, we drain it by the incising of, so that is the incision given to the tympanic membrane, and that's how we remove the infection or the suppurations from the middle ear cavity. Tympanic membrane is one of the structure, in fact, not only tympanic membrane, ear ossicles, that is the bones of the ear, middle ear cavity, cochlea, semicircular canal, they never grow in size. जो साइज बर्थ के टाइम पे होगा वही साइज आपका एडल्ट में रहेगा। सो इफ यू आर बोर्न विद अ सर्टेन साइज ऑफ द tympanic membrane or bones of the middle ear, or cochlea, semicircular canal, the size of the middle ear cavity, not the eustachian tube. So these things, they will not change afterwards. So they remain more or less the same itself. So that is why there will not be much of a difference in the approach toward the middle ear in case of a children or in case of an adult, because the anatomy, the size doesn't change in adults. So basically they are of adult size at the time of birth. Let's now get to the next topic of ours today, and that is the norma basalis. So we'll talk about the norma basalis, and the reason I'm discussing the norma basalis with you today, because along with this norma basalis, I will explain you another triangle which is present at the back here, and the joints of the neck, the atlanto-occipital and atlanto-axial joints, can be understood if you know a few muscles there. First, a very clear-cut and open suggestion to you all: please do not waste time in understanding the attachment of these muscles. ये मैंने आपको पहले ही बोला था, you don't waste your time in remembering the attachment of rectus capitis superior, semispinalis capitis, cuneus capitis. You just need to know the location of these muscles, where they are inserted on the base of the skull, and that is it. That will tell you what kind of movement they can produce. Do not unnecessarily waste your time about detailed attachment of any of these muscles at all. Now, I'm not going to repeat the rest of the part. I hope you remember we discussed this portion already, the anterior part, right? We discussed about all these muscles which are attached here, muscles of mastication and also the palate muscles, the eustachian tube ke paas jo muscle, the levator veli palatini, tensor veli palatini. So basically we're done with this part. Now today I want to look at this part of the norma basalis. Okay, here we go. And see, I want you to please understand the nomenclature of these muscles and watch these or look at these muscles with respect to the occipital condyle. Now, where is occipital condyle, guys? These are the occipital condyles. So this is the first and the most important thing that you need to remember here. These kidney shaped, or you can say elliptical shaped occipital condyles are present here. I'm going to share the same image with you. तो मुझे जरा आराम से label कर देना इसको. These are occipital condyles. And the reason I want to discuss the muscle in relation to this, these occipital condyles, because this is going to make a joint called as atlanto-occipital joint. But atlanto-occipital joint में कौन सी movements होती है? The movement at the atlanto-occipital joint is this movement. There is a flexion and the extension of the neck. That is called as the yes movement. When you nodding करते हैं आप yes करते हैं, ठीक है? And lateral flexion, which is like this. When you do a movement like this. So these movements can take place here. So how will you remember that what muscle is responsible for that movement is very easy by remembering what muscles are arranged around it. If a muscle is present in front of this condyle, then obviously will help you to flex the neck. That is yes movement. If it is behind, all these muscles present behind will help you extend the neck like this. And the muscle which will be on the side here, on the lateral side, will help you in the lateral flexion of the neck. So if you know the osteology here, the difficult part of the atlanto-occipital joint will be covered, and that is how exactly the muscles are going to move at this particular joint. Okay. Now, first thing, this here, in the center, this is basically the point where the pharyngeal tubercle is present. Remember pharyngeal tubercle, where the pharyngeal raphe is attached, gives attachment to all the superior, middle, inferior constrictor. So this is the point of attachment. This is the point of attachment of this is the pharyngeal tubercle present here. And one of the muscle which is directly attached to the pharyngeal tubercle is the superior constrictor muscle. So this red color here is shown for one of the origin of superior constrictor is here as well. The muscle that you see just beside it, and again I will say, it is in front of this. It is in front of this. This muscle here is called as longus capitis. This muscle is called as longest capitis. But a capit means head. So these muscles are attached to the base of the skull, base of the head. So we call it longest, the capitis muscle. Please be careful. This is longest capitis. This is not longismus capitis. बस ये difference याद रखना. It is longest capitis, not longismus. That's a different muscle. That's a longest capitis. Another muscle which is present in front here is this one. Exactly in front of the occipital condyle. These are occipital condyles. I'm writing OC. There is occipital condyles. The muscle which is present in front is, but this muscle is called as a rectus capitis anterior. Rectus means straight, capit means head, and anterior, obviously anterior to the joint. So we call it rectus capitis anterior. Now, this is telling you guys that rectus capitis anterior and longest capitis muscle both are present in front of the atlanto-occipital joint. So they both will help in what movement? They both are going to help in the flexion movement at the neck, at the atlanto-occipital joint, to be more precise. तो बस ये याद रखना आपको. Nobody is going to ask you, even in the osteology, Viva, I can guarantee you nobody is going to ask you the muscle on the base of the skull here. But you got to remember it to understand the other topics. Okay, the muscle that you see on the side here, on the side of the occipital condyle, again on the occipital bone itself, this muscle is called as, this muscle is present on the side here. It is again a straight muscle. These are the straight muscles going to the head. So they are all rectus muscle. Rectus, capitis, but lateralis. This muscle here is the rectus, that is straight, capitis to the head, lateralis toward the lateral side. Rectus, capitis, lateralis. It helps in what flexion? It helps in the lateral flexion of the neck. Or you can say the side flexion, like this. When you do this movement, this lateral flexion or the side flexion. Now before I tell you the names of the muscle present behind, कुछ छोटे से some bony prominence that you need to understand, beta. This here is the external occipital protuberance. There is an external occipital protuberance. This protuberance, there is an internal occipital protuberance also, where we have the confluence of the sinuses. This is external occipital protuberance, and exactly in the line of this guys, अगर मैं इसको थोड़ा सा आपके draw करूँ यहाँ पे, this here, in fact I should draw it on this side. This line which is running here is a superior nuchal line. That's a superior nuchal line. And there's another line which is not shown here, very faint though, actually this line which is present here, that will be the inferior nuchal line. Inferior. That's a view from the below, so obviously that will be the superior, this is a more inferior nuchal line. And this crest over there is called as external occipital crest. That was a protuberance. This crest here is an external occipital crest. Not very important to remember, but just remember there is external occipital crest. Okay. If this muscle was rectus capitis anterior and this was rectus capitis lateralis, so obviously behind will be the rectus capitis posterior, but there are two. We have two rectus capitis posterior. The one which is inside is smaller and that is called as a minor, and the one which is outside is a larger and that is called as major. So because the name of the muscle here is, this is inserted inside and this is inserted outside. Both are rectus capitis posterior. This also is a rectus capitis posterior, but the one inside is minor and the one outside is major. Rectus capitis minor and rectus capitis major. Obviously, both will help in the extension. But again, this is not the only muscle. This is not the only muscle which will help in the extension. If I come more posteriorly, there is a muscle which is inserted here, and this muscle is a semi-spinalis capitis. Guys, this muscle here is the semi-spinalis capitis. If you remember, this semi-spinalis capitis was also present in the floor of posterior triangle. Semi-spinalis capitis. More posteriorly, on this superior nuchal line, you will see the origin of what muscle? The trapezius muscle. Trapezius muscle. You know, trapezius का ऊपर वाला attachment nuchal line पे होता है यहाँ पे. That is the trapezius muscle. And if I look at the muscle which are attached to the mastoid process, well, again, I don't have to go into the detail of every muscle here. Like this is the origin for the posterior belly of digastric. The huge origin is for the sternocleidomastoid. Not bothered about it. I am bothered about the muscle जो पीछे आ रहा है यहाँ तक. This one. This muscle is splenius capitis. This muscle here is a splenius capitis. This muscle here is a splenius capitis. Now look at this. Let me just highlight this for you so that it will be easy for you for the later part. Guys, rectus capitis posterior minor, rectus capitis posterior major, splenius capitis, semispinalis capitis, and trapezius. If you look at all these muscles, let me highlight them in the picture also, and you compare it with the occipital condyles, all these muscles are present behind the occipital condyle. The part of this muscle here, this one, and this one, they're all present behind the occipital condyle. All of them will help in what? Extension of the neck. All of them are going to help in the extension of the neck. There is no easy way to remember these muscles. That's the only way I believe that you remember these muscles on the image, find out the foramen magnum, locate the occipital condyles, and obviously occipital condyle का आपका atlanto-occipital joint present होगा. Now look at the muscle, what is anterior, what is lateral, what is posterior. So we have muscle in front is longus capitis and rectus capitis anterior. On the side, that is rectus capitis lateralis. Behind rectus capitis minor and major. More posteriorly we go, then we have semispinalis capitis, splenius capitis side mein, and then more posteriorly we got trapezius muscle. Just for the sake of completion. Now this is, I have labeled the muscle that you should remember for the topic on the right side of this image, and toward the left side, let me label a few more muscles here. But again, you don't have to remember those muscles as such in this section here. Like that's a mastoid process, obviously, guys. This process here is the mastoid process. So this is the insertion of sternocleidomastoid. सबसे पहले obviously the insertion of sternocleidomastoid, and inside, look at the red color, innermost muscle that you're looking at here, that is the origin of posterior belly of digastric. Insertion of sternocleidomastoid, and that is the origin of posterior belly of digastric. But you know muscle here. You already know this one here. That was what? That was a splenius capitis muscle. That is a splenius capitis muscle. And this muscle here, which is remaining here, this one is called as the longismus capitis. Longismus. Write it and forget about it. Go forget about it. Longismus capitis muscle. Nobody's going to ask you. But just please remember, do differentiate the longismus capitis from what? From longus capitis. Longus capitis is present in front. Longismus capitis is in relation to the mastoid process. And finally, there's another muscle which is left here, which is very much on the side here. We are not going to use this muscle for anything as such for the discussion in the atlanto-occipital joint. Now, again, how will you name this muscle? It's easy to remember this muscle, guys. This muscle is again a capitis muscle. This is a capitis muscle. Now, this muscle is called as obliquus capitis, and we have to call it superior because there is another muscle present within the cervical vertebrae. We call it inferior. I will tell you about that muscle. This is called as the obliquus capitis superior. Obliquus capitis superior. Not important, guys. Not important as of for the what do you say? From the questions or from the understanding point of view. The muscle which are important, which I would say that you should revise them before you read about the atlanto-occipital or atlanto-axial joint, are the one on the right hand side here. The one in front causing flexion, the one on the side causing lateral flexion, and the one behind causing the neck extension at atlanto-occipital joint. So let's talk about the atlanto-occipital joint and atlanto-axial joint, and then we come back to the another triangle which is formed by these muscles itself. How can we understand the atlanto-occipital and atlanto-axial joint? Before we should talk about something about the cervical vertebrae. We need to know about the features of cervical vertebrae, then only we can understand these joints. Sorry. So guys, let's have a discussion on the cervical vertebrae first, and then we'll go to the joint part here. Guys, cervical vertebrae, the first cervical vertebrae C1, as you all know, is called as the atlas. The second cervical vertebrae is called as the axis. C3 to C6, these cervical vertebrae are typical cervical vertebrae, which I will discuss with you first. Typical cervical vertebrae. And C7 vertebra is the one which you can feel. If you look at the base of the neck, posterior side, you can feel an elevation over there. If you touch the back of the neck, very close to where the neck is attached to the rest of the trunk, if you feel there is an elevation, a prominent elevation which is seen here, that elevation is because of the spinous process of C7. So C7 basically is a vertebral prominence. Vertebral prominence. C7, it forms a vertebral prominence, that elevation that you feel at the back of the base of the neck, that is called a vertebral prominence, formed by the spinous process of C7. So guys, these are atypical. C1 is atypical. Atlas. C1 is atypical, C2 is atypical, and C7, which is forming a vertebral prominence, is also atypical. Let's talk about a typical cervical vertebrae, and then we will move on to the thing. Okay, let me copy a picture for that again, and then again, guys, we can draw it, but there's no need because nobody is going to ask you to draw the picture of a vertebrae, so I'll make 2 times waste for nice paper. Again, let me use an image here, and again, I'll share the image. This is a picture of a typical cervical vertebrae, and you're seeing it from the top. Now, some feature of the cervical vertebrae which separates it from other vertebrae. The two main features, just say cervical vertebrae, the two important features of a typical vertebrae. One, that spinous process is bifid, as I divided it, and presence of foramen transversarium through which the vertebral artery will pass. So that's that. Once you look at the vertebrae, the two most important features here. Okay, first let me start with this. The body. Body of a typical cervical vertebrae. The important feature to understand here is that the transverse diameter is more than anterior posterior diameter. You can see that this transverse diameter here is more, and the anterior posterior diameter is less. So the transverse diameter is more than anterior posterior diameter. I'm trying to write a bit neatly so that I can share this picture with you. Right, that is one thing. There's a on the side of this cervical vertebrae, you will see, if you look at the upper part of the body, there's a lipping. There's an edge which is coming up. There's an edge which will be prominent on the side, on the superior articular surface, on the upper part of the body. The sides are slightly edged above here. So if the sides are edged above, the upper surface of a typical cervical vertebrae will look like a concave from side to side. It will look like a concave from side to side. So body has a transverse diameter more than anterior posterior diameter, and secondly, it is concave side to side. Slightly concave side to side. Second important thing, vertebral foramen. If you look at the vertebral foramen where the spinal cord will be present here, right? The vertebral foramen is large compared to the thoracic vertebrae. We have a larger vertebral foramen present in the cervical vertebrae, and that is triangular in shape. The shape is triangular, guys. So this here is a vertebral foramen. There's a vertebral foramen which is large and triangular. It is large and triangular in shape. This is obviously what? That's a bifid spinous process. Bifid spinous process, which is again a typical feature of a cervical vertebrae, or किसी vertebrae में आपको नहीं मिलेगा. We have a short spinous process and they are bifid, they are divided. You have a bifid spinous process, इनके बीच में एक ligament भी present होता है. That ligament is called as ligamentum flavum. Okay, now अब आते इस बात पे. This, I hope you all know this portion of the vertebrae. For any vertebrae, this is the one which is connecting the body to the lateral mass is called as the pedicle, and the one which is connecting the lateral mass to the spinous process is called as the lamina. But that is pedicle and this is lamina. Obviously, lamina is longer and pedicle is short. That is there for the every vertebrae. The important thing is that first of all, this here is a pedicle. And extending from the body in the pedicle, that whole thing is a transverse process. Now, transverse process are having some elements here. What are the elements of the transverse process? This root here is called as the anterior root. Please understand this because there is something important coming up here. This is the anterior root. This root here is called as the posterior root. Obviously, this tubercle will be called as what? Anterior tubercle, because it is anteriorly placed, so we call it anterior tubercle. And similarly, this is called as the posterior tubercle. Anterior root, posterior root, anterior tubercle, posterior tubercle. So anterior root is ending as anterior tubercle, and posterior root is ending as a posterior tubercle. And the one which is connecting both the root, this here is called as the costo-transverse bar. The word is costo, that is for the ribs actually. Costo transverse bar, which is connecting the anterior and the posterior tubercle. तो बेटा cervical vertebrae पे obviously ribs तो attach है नहीं. Ribs are not attached to the cervical vertebrae, but ribs do have a component. Cervical vertebrae do have a component of the rib. Rib basically, developmentally also, ribs are the extensions which are coming from the vertebrae itself. So even though we do not have a rib attached to the cervical vertebrae, but some costal element is also present there. We have some costal element there. Now what is the costal element? Which part of this entire thing that I have labeled here is called as a costal element of the vertebrae, of the cervical vertebrae? I'm highlighting it for you. Anterior root, anterior tubercle, costotransverse bar, and posterior tubercle, but not posterior root. That's important. Not posterior root. These are called as the costal elements. These are the costal elements. So basically, in the lower vertebrae, like in the thoracic vertebrae, this is the part of the vertebrae which will give rise to the ribs. Anterior root, anterior tubercle, costotransverse bar, and posterior tubercle, not the posterior root. So these are all called the costal element of the cervical vertebrae, typical cervical vertebrae. And because of this costotransverse bar, between the pedicle and the costotransverse bar, there is a foramen over there. Now this foramen, which I am putting an asterisk sign here, this foramen is called as the foramen transversarium. That is called as foramen transversarium. And this foramen transversarium, it transmits what? It transmits the vertebral artery. It transmits vertebral artery. More precisely, it transmits the second part of vertebral artery. So again, I told you the vertebral artery is a topic of neuroanatomy actually to be discussed there. So it transmits the vertebral artery. More precisely, the second part of vertebral artery. Obviously, this is the lateral mass here, and lateral mass is having the articular facet. This is the superior articular facet. That's the superior articular facet. ऐसे नीचे होगा, that will be the inferior articular facet. And the superior articular facet of this vertebrae will articulate with the inferior articular facet of the other vertebrae, and that joint which they form is called as the zygapophyseal joint. Superior articular facet with the inferior articular facet of the vertebra above, जिसके ऊपर vertebra होगी, that joint is called as the zygapophyseal joints. And these zygapophyseal joints are the variety of the plain synovial joint. They are the variety of plain synovial joint. That's it. Just don't have to remember any other nonsense from this thing. Remember the features over there. Body is small, relatively body is small only, but you can see the transverse diameter is more than the anterior posterior diameter, and body is concave from side to side. When you see from above, ऊपर अगर देखोगे तो it is concave from side to side. Okay. Then we have these. The pedicle is there, lamina is there. Pedicle is shifted actually more toward the what do you say, anterior laterally, and that's why the vertebral foramen is triangular, large and triangular in shape. We have a foramen transversarium, and the costal elements are surrounding it here. Anterior root, anterior tubercle, posterior root, posterior tubercle, costotransverse bar. Posterior root को छोड़ दे, बाकी everything is called as a costal element. And as we said, this foramen transversarium is giving passage to the vertebral artery, to the second part of vertebral artery. Now, this is a typical cervical vertebrae. Seventh cervical vertebrae is different from it because seventh cervical vertebrae looks more like a thoracic vertebrae, guys. When you look at a seventh cervical vertebrae, उसकी जो shape है, the seventh cervical vertebrae may not have a foramen transversarium, number one. And secondly, second thing is that the spinous process of the seventh cervical vertebrae is very long. Seventh cervical vertebrae, the spinous process is long and not bifid. That is the one which is forming this vertebral prominence here. So that is how the seventh vertebrae is different from the typical cervical vertebrae. Though important feature are that no foramen transversarium. Foramen transversarium can be there, but that is rare. But usually there is no foramen transversarium, number one. And number two, we have a long spinous process which is not bifid. So spinous process is more like a thoracic vertebrae in case of the seventh cervical vertebrae. अच्छा, एक और चीज, an important thing that you should remember, that anterior tubercle of sixth cervical vertebrae is known as carotid tubercle. Anterior tubercle is present in all the typical cervical vertebrae, but the sixth cervical vertebrae, anterior tubercle, is more prominent, and it is called as a carotid tubercle. Why do we call it carotid tubercle? Because when you feel the pulsation of carotid artery, you press it against the carotid tubercle only. So basically, it is present against common carotid artery. So when you feel the pulsation of the common carotid artery, you basically push it against the carotid tubercle only, against the tubercle of the sixth cervical vertebrae. So point is that anterior tubercle of sixth vertebrae is called as a carotid tubercle, which is present against the common carotid artery. Okay, so ये तो guys regarding the typical cervical vertebrae. Now, atlas and axis, the first two cervical vertebrae, which needs a little special discussion here. Again, we got to see the features here. Let me just take you to the atlas vertebrae directly first. So this is the atlas vertebrae. What is there and what is not there? You know, first of all, why we call it atlas? The word atlas, you must have seen this. Sometimes there used to be old Bollywood movies also in which they used to show a man which is holding the entire globe. So that man is the atlas actually, holding the entire heaven or the entire globe. So that is the atlas. So the superior facet of this vertebrae is basically holding the entire skull. This is the one which is forming the atlanto-occipital joint. So occipital bone is attached at here and forming the atlanto-occipital joint. So that's a name given to its atlas here. What is the feature of the atlas that you see? The सबसे striking feature आपको क्या दिख रहा है? The two most striking features is number one, there is no body. We don't have body here. We have an arch. We have a posterior arch, anterior arch and posterior arch, but there is no body here. So in the atlas, the two important thing here is that number one, that there is no body, and number two, no bifid spinous process. As a matter of fact, there is no spinous process as such. We just have a tubercle only on the back. So what is then there? There is no body, there is arch. We have a small arch which is called as the anterior arch. That is called as the anterior arch of atlas. So we don't have a body in the first cervical vertebrae, and this larger arch here is called as the posterior arch of the atlas. That was the anterior arch, and this is the posterior arch of the atlas. This is the superior view, guys. Again, whatever vertebrae I'm showing the superior view only. This anterior arch is having a tubercle in front, and that tubercle is called as the anterior tubercle. There is an anterior tubercle and it is giving attachment to one of the ligament called as an anterior longitudinal ligament. We'll discuss that. Let's not go into that. There's a ligament that you will see attached to it. Posterior arch. The very important feature of the posterior arch is that there is a notch present over there. Can you see that notch over there, guys? So this notch का काम क्या है? Vertebral artery. What happens is vertebral artery comes out of this foramen transversarum. Now obviously vertebral artery is running through the foramen transversarum of all the cervical vertebrae, and this is the first one. So after it comes out of the foramen transversarum of the first cervical vertebrae, it has to go through foramen magnum into the cranial cavity. एक बार vertebral artery यहाँ से बाहर आ गया, then it has to go above into the cranial cavity through foramen magnum, and foramen magnum is present at this level. If I put this vertebrae on the skull, foramen magnum is present exactly at this level only. That means vertebral artery has to come from here inside. And how it will come from here from inside? It's like this. So vertebral artery will come in like this, and will use this arch, posterior arch, to come inside and then enter through foramen magnum. So this sulcus or depression that you see on the superior surface of the posterior arch of atlas is giving passage to number one to the vertebral artery. And this is basically the third part of vertebral artery now. Third part of vertebral artery, and it is also giving passage to the first cervical nerve as well, the C1 nerve. The C1 nerve is also coming out from there. But a C1 nerve कहाँ से बाहर आएगा? C1 nerve will come out between the base of skull and first cervical vertebrae. Between base of skull and first cervical vertebrae. So it will come out from here. So we have a sulcus present here. We have a depression which is present here on the superior surface of the posterior arch of atlas, which is providing the passage for the vertebral artery to go inside and C1 nerve to come outside. Let me just draw this arrow so that you have no confusion. It is going inside and the C1 nerve is coming outside. We said this is a large posterior arch which is having a tubercle here, and this tubercle is called the posterior tubercle. This is a posterior tubercle. Like we have anterior tubercle, this is a posterior tubercle of the atlas. Some important attachments I'll tell you when it is needed. It's not needed here. The important thing is, again, this is foramen transversarum, nothing to discuss. This is foramen transversarum giving passage to the vertebral artery. Here is the articular facet that we're talking about. This is the superior articular facet. And this superior articular facet is the one which will form what joint? Atlanto-occipital joint. This is the one which will form the atlanto-occipital joint, which is our next topic also. So I'm just writing the atlanto-occipital joint here. Another important thing to be noted is that this lateral mass, this entire lateral mass, can you see a prominence inside? This prominence which is inside toward the foramen magnum will provide attachment to the ligament. Guys, there is a ligament which will attach to this prominence inside, and that ligament running from one eminence to the another eminence is called the transverse ligament. There is a transverse ligament. Basically, transverse ligament, between the transverse ligament and the anterior arch of the atlas, the odontoid process of the second cervical vertebrae will be present here. Second cervical vertebrae is what? Axis, and it is having a process which is called as odontoid process, also called as dens. So dens of the second cervical vertebrae is actually passing inside the arch of the atlas, and it is kept, this odontoid process or the axis of the second cervical vertebrae, which I'll show you immediately after that, is kept in its position by these two things. आगे arch है, पीछे ligament. This ligament is very important, guys. अगर ligament rupture हुआ, so that is the when you hear about the cases that to be hanged till death. To be hanged till death, the death is actually because of rupture of this ligament, and I tell you what exactly happens when this ligament ruptures. But you should know as of now that the dens is supported by this ligament on the posterior side, and that is the transverse ligament of the atlas. From the atlas, if I take you to the axis vertebrae, obviously the one which is having this extension, and this extension can be seen more from the posterior side. Guys, so what happens is, we said first cervical vertebrae is not having a body. If I take you back here, if first cervical vertebrae was having a body, that body will be present in this region only. That means dens, basically, developmentally dens was the part of first vertebrae itself. Developmentally dens was the part of first vertebrae, but something happened, and what happens is this dens actually separates from the first vertebrae and becomes the part of second vertebrae now. So first vertebrae is not having a body now, and second vertebrae body is having an extra extension coming up, which is called as odontoid process or the dens. अगर आप सामने से देखेंगे, the picture looks like this. So this was a normal body of the second cervical vertebrae when you see it from the front, and this extension here is called as the odontoid process. Odontoid process, also called as the dens. So this dens is the one which is extending upward and which is surrounded by the arch of the atlas, anterior arch of the atlas. और उसके पीछे क्या ligament था? There is transverse ligament. So the second vertebrae, there is nothing much to discuss here. The only thing that you need to look here is that on the body, on the superior surface of the body, we have this process called as the odontoid process, and that makes it unique. That makes it atypical here. So that process here is the odontoid process or the dens. बाकी सब कुछ more or less same है. We have bifid spinous process there. Foramen transversarum is also there, although it is hidden in this picture, but it is there. So rest everything looks more or less the same, like a typical cervical vertebrae itself. If I put an atlas and axis together, that atlanto-axial joint, let me just show you how the picture will look like, and then we can come to the joint part. That's how it is, guys. Look at this. That's an atlas and the axis. Now you can see what is that? That is the dens over there. This is the dens or the odontoid process. That ligament, what is that ligament? The transverse ligament can be seen. Let me just label it for you. There is a transverse ligament of atlas. It's a ligament of atlas which is supporting the dens. Okay. So this joint here is what joint? That is called as atlanto-axial joint. We will be talking about this joint next. First we'll talk about the atlanto-occipital. So that is the atlanto-axial joint, or if joint side over, that will be atlanto-occipital. Now there are many ligaments which are connecting the dens to the foramen magnum, to the margin of foramen magnum also. And those ligaments, those membranes, the name will change for them when you look at the different view. Let me discuss first the atlanto-occipital joint with you. Then I'll make you draw a certain diagram in which we'll keep on adding these details of what ligaments are connecting the dens to the foramen magnum. What is apical ligament of dens? What is membrana tectoria? What is cruciate ligament? All those. So let me first go with this joint, on which again you get a short notes only. That is an atlanto-occipital joint. It's between the atlas and the occipital bone. Atlanto-occipital joint. Now you already know the articular surface. Atlanto-occipital joint is between the atlas, superior surface of the atlas, and then occipital condyles are there. So the type of this joint. This this is a type of ellipsoid joint, or you can say ellipsoid variety. आपने shape देखी थी? If you remember the shape of the atlas, if you remember the shape of the superior articular facet of the atlas, which I quickly show you, look at the superior articular facet is what? It's elliptical in shape. So obviously it's an ellipsoid type of synovial joint. It's an ellipsoid variety of synovial joint. Articular structures. If you look at the articular surface, well, above, what is the articular surface above? Articular surface above is basically slightly convex, and that is occipital condyle. Occipital condyles are convex, and atlas का जो superior articular facet that is concave. They are elliptical in shape, but this is a slightly convex and it is concave, which fits into it. So above the articular surface is, if I go with the shape, it is slightly convex. Below the lower articular surface is slightly concave. What is that? Above articular surface is by what? It is by the occipital condyles. It is formed by the occipital condyles. And below the concave articular facet, it is by the superior facet or superior articular facet. Superior articular facet of atlas. वो भी आपने देखा था superior articular facet, which looks a little like this. It looks like kidney shape, a constricted kidney from the center, like this. It is constricted in the middle part. So you talk about regarding the articular surface above and below. That's how we answer any question on the joint. We talk about the variety, we talk about the articular surface, then we talk about the ligaments, then we talk about the muscles and the action, nerve supply, the blood supply. So it's a short note question itself. Ligaments. What ligaments are supporting this joint? What ligaments are supporting this joint? Okay, so this is another again a part of a lecture where you have to use your imagination a bit. Guys, to understand the atlanto-occipital joint ligament and also to understand the atlanto-axial joint ligaments, I want you to draw one diagram with me. Again, let's go nice and easy in this, but you have to understand how the section is taken. Right? The section is a sagittal section. If you take exactly a mid-sagittal section from the region of these joints, obviously, so which are parts of the sagittal section, in which you can see the cervical vertebrae and the occipital bone, how it will look like. Now, let me draw this for you, and this is a diagram which I'm not going to complete at one go. This is a diagram which I will complete like part by part. So make sure to draw it neat and clean and slightly bigger. Right, when you take a sagittal section, the section obviously from the posterior part will go through foramen magnum. Each sagittal section will go from foramen magnum, and if I compare this in here, the mid-sagittal section will go something like this, right? Like this. Now I want you to imagine all these things here first. If the section is going like this, the first thing that you see above is the margin of foramen magnum. Let's say this circle is a foramen magnum. So you will see the posterior margin of foramen magnum, you will see the anterior margin of foramen magnum. Let me do that from this picture. Below that, you will see anterior arch of the atlas, you will see posterior arch of the atlas. Below that, you will see what vertebrae? You will see the second cervical vertebrae, the body of second cervical vertebrae with the odontoid process coming inside the arch, anterior arch. Right? So these are some things that you need to keep in mind when you take a sagittal section here. अगर आप ये समझ के section कैसे लिया है, rest is nothing. That's very very simple. So all understanding here is about how the section is taken. So to understand the ligament, we are basically going to take a sagittal section. So there we go. This, let's say, is a part of the occipital bone at the back. This here is occipital bone in the front, and in between obviously there is a foramen magnum. So but ये तो हो गया बीच में foramen magnum. The space in between, this is a foramen magnum. This here is the basilar part of which bone? Occipital bone. So take a section like this, so I can, if this is a foramen magnum, guys, if this is a foramen magnum, and if I take a sagittal section, so I'll see some part in front and some part behind here. Both basilar part of occipital bone will be seen, and the space in between is what? It is a foramen. So it's a view from the side. So आपने specified cut sagittal section. So all you can see is the anterior part and the posterior part of the foramen magnum. That is basically occipital bone. Okay. Now, if imagine this is the anterior side of this picture, and there is a posterior side. If I give you the side orientation here, the section goes like this. The sagittal section is in this way. This is superior, inferior. Here is anterior, and there is posterior. So that's the anterior side of it. So you will see what? You will see the anterior arch of the atlas, guys. You here will see the anterior arch of the atlas. And posteriorly, this is the posterior arch of the atlas. Makes sense? When the section goes from the first vertebrae, we have anterior arch, posterior arch, is कुछ है भी नहीं. So this here is the anterior arch of the atlas. Please take your time. If you have any confusion, you just stop me in between. You can ask me again, but I want you to understand this diagram here. लोग इस diagram बना लेते हैं, लेकिन आधे ज़रूर बनाएंगे. Anterior arch of the atlas, and this here is the posterior arch of the atlas. What is the next thing I expect to see, guys? The next thing I expect to see below here is again the posterior part of second cervical vertebrae, which is nothing like a simple thing. Lamina will be there. Anteriorly, क्या दिखेगा आपको? Body, huge body will be there, and that body is extending above as what? Odontoid process, behind the anterior arch, behind the anterior arch. So this is something gonna be in this way. Here's the body, and there is extension. Right. So that's a C1 vertebra. That's a atlas here. This is axis. There is an axis body. The body of the axis vertebrae, and that is odontoid process. I'm just writing D for the dense. That is D for the dense. और उसके नीचे then we have third vertebrae, fourth vertebrae. Then that's a normal scenario, कुछ कोई nothing new. That's the body of the third cervical vertebrae, the anterior part. That is the posterior part. That is how it's gonna look like. So obviously you will see the odontoid process. The dense is extending. Where? Dense is extending inside or posterior to the anterior arch of the atlas. और उसके पीछे ligament with the transverse ligament was there. Trust me, if you are able to understand this part here, what exactly you're looking at, if your imagination is serving you well here, आगे वाला part I can make you very easy understand. We are taking sagittal section, and when I'm talking about right now about the sagittal section, don't think about the face and everything, just think about the posterior part. So there is a foramen magnum. Now look at this is foramen magnum here. Okay. Then we have atlas vertebrae, and then we have axis vertebrae. Now this is that's a foramen magnum here. अभी foramen magnum कहाँ present है? Foramen magnum is present in which bone? Occipital bone. If I just take you back here for 1 second, your foramen magnum here is present where? That's a foramen magnum present in the occipital bone. So if I take a diagonal section like this, exactly like this here, so I will see this part of the occipital bone and I will see this part of the occipital bone here. So that is again a basilar part, and that also is that is again an occipital bone. That I would say this is a basilar part because basilar artery is in relation to that. That is a basilar part of occipital bone, and that's an occipital bone simply. So occipital bone will be seen anterior and the posterior margin of foramen magnum. So that is the first thing you are seeing here in this picture. That's a basilar part of occipital bone, and that again is simply occipital bone. और बीच में space है ये foramen magnum है. Don't draw this, but this is foramen magnum in between. Next vertebrae is a first cervical vertebrae. First cervical vertebrae में body is not there. So we have anterior arch of the atlas, we have posterior arch of the atlas. That's what we saw. Is anterior arch or posterior arch. So section is going from the anterior posterior arch. उसके नीचे second vertebrae. Second vertebrae is having body. It is having the posterior part also. But second vertebrae की speciality is the having a dens or the odontoid process, which was extending behind the anterior arch, which we saw in this picture also. Behind the anterior arch, the dens is projecting inside. So if I take a sagittal section from here like this, so just behind the anterior arch, the dens will be seen. That is what you're looking at. So now come to the business end of this thing here. There are ligaments which are connecting all these. We call posterior side, these ligaments are called as ligamentum flavum. We're not interested in that part of it as of now. But from the posterior arch of the atlas, to the posterior margin of the foramen magnum, or you can say posterior margin of which bone? Occipital bone. There is a membrane present. We don't call it a ligament, we call it a membrane. And this membrane is called as, because it is present on the posterior side, so we call it posterior atlanto-occipital membrane. Posterior atlanto-occipital membrane. Atlanto-occipital, between the atlas and the occipital bone. Let me write that again. There is nothing but the occipital bone only. So posterior atlanto-occipital membrane. I'm going to use certain highlighters here, which I want. अगर आपके पास वो highlighters are different color, just mark them with those highlighters, which I'm going to do it with. You will see it now, and you will understand it better in the upcoming part here. Okay. And as I said, I just have to focus on the first and second vertebrae only. I'm not going beyond that. उसके नीचे सोचने की जरूरत नहीं. Now we all know that body of the cervical or thoracic or lumbar vertebrae, they are having one ligament in common, that is anterior longitudinal ligament and posterior longitudinal ligament. पूरी vertebral column में body, in front of the body and behind the body, there are two ligaments. We call it anterior longitudinal and posterior longitudinal. So बेटा जो ligament यहाँ पे present होगा, one which is in front of the body, draw it in the lower part only. That ligament will be called as anterior longitudinal ligament, right? So this whole thing, even till here, till the anterior arch of the atlas. This is anterior longitudinal ligament. और नीचे जाएगा पूरा 3, 4, 5 and all of the vertebrae. And the ligament present behind here, this is posterior longitudinal ligament. Try to label them exactly where I'm doing it. This ligament here is present in front of the body of vertebrae, so we call it anterior longitudinal ligament. This is present behind, we call it posterior longitudinal ligament. Right? Anterior longitudinal ligament is extending till the atlas vertebrae, also to the anterior arch of the atlas also. Here's the point. Now, from the anterior arch of the atlas, guys, look at this, and I'm using a different color for this. From the anterior arch of the atlas to the margin of the basilar part of occipital bone, or simply you can say to the margin of foramen magnum in a way, there is a membrane present here as well, and this membrane is in front. बेटा जो membrane पीछे थी वो क्या थी? Posterior atlanto-occipital membrane. This membrane is in front. It is called as anterior atlanto-occipital membrane. One question here is, atlanto-occipital membrane is just the continuation of what? Anterior longitudinal. In the rest of the vertebral column, we have anterior longitudinal ligament, but by the time we cross the first vertebrae, above first vertebrae, the same anterior longitudinal ligament extends as a membrane called as anterior atlanto-occipital membrane. Atlanto-occipital membrane. So, anterior atlanto-occipital membrane is an extension or the continuation of anterior longitudinal ligament. That is one question. So, try to give them same highlighter or underline with the same color, whatever you have. But then there is a ligament which is present, I'm again using a different color, from the tip of the dens. From the tip of the dens to the exact margin of the foramen magnum here. We've talked about this ligament as a remnant of notochord also, and this is called as the apical ligament of dens. There is an apical ligament of dens. It is one of the remnant of notochord. Apical ligament of dens. It is one of the remnant of notochord. ये बिल्कुल dense के tip से start होता है, and it goes to the margin of the foramen magnum, or you can say to the basilar part of occipital bone. Okay, what is the ligament you expect to see behind the dens? अभी देखा था हमने. What is the ligament? Now look at this. I want all of you to please follow here for 1 second. But the ligament which is present just behind the dens is a transverse ligament. But the thing is, right now you're looking into the transverse section, so I can only see the transverse ligament. The same transverse ligament is having a fibrous, like this is a transverse ligament which is present in front of dens. Let's say this glass here is a dens. इसके सामने transverse ligament present है इसके. In fact, सामने के पीछे present is transverse ligament. But this transverse ligament is also having an extension going above. We call it superior band, and we have inferior band. So imagine if you have a transverse ligament which is also giving off the superior and the inferior band. It looks like this, and that is called as a cruciform ligament. Crisscross, cruciform ligament, which will look something like this. I'm showing you a picture of how the cruciform ligament will look like, and that you can appreciate in this image. देखो, have an orientation बेटा. First, posterior arch of the atlas is cut. आपको show करने के लिए posterior arch of the atlas is cut. Posterior margin of foramen magnum or the occipital bone is also cut, so that you can see inside. So that's a view from the posterior side. Now, this ligament here is the transverse ligament. This ligament here is the transverse ligament. And this transverse ligament is showing an extension going above. They have cut it though, but it is shown here. Let me just connect these two. This is basically connected here, and one extension is going downward. So this is a superior band. The one which I'm highlighting here, that is a superior band, and the one which is going here, that is an inferior band. And together, it is called as what ligament? The cruciform ligament. So it is not only the transverse ligament that we have behind the dens, because it's a view from the back, We also have a superior and the inferior band, and collectively we call them the cruciform ligament. The cruciate ligament बोलते हैं, cruciform ligament बोलते हैं. Cruciate ligament is a more commonly used term in the knee joint, so we usually call it a cruciform ligament. The crisscross. And because now again understand, because this view is from the posterior side, so if I rub this thing, they have cut this superior band. Can you see another ligament over there? That is the apical ligament of the dens. That is apical ligament of dens. Let me go take you back to this picture, the one which we drew, and let's see if you can correlate the two things. So we have this apical ligament of the dens. We said behind we have a transverse ligament. Now because this is sagittal section, so transverse ligament will look only like this. But superior band and the inferior band can be seen. But the superior band will go above again to what? To the basilar part of the occipital bone. And inferior band will come in front where? Till the body of axis. So that's a superior band and the inferior band of cruciform ligament. Superior band and inferior band of cruciform ligament. I will label it in a minute, but let me label one last thing here. What ligament is that? Posterior longitudinal ligament. But you see posterior longitudinal ligament is ending where? At the body of second cervical vertebrae. Is it the end? No, it is not the end. After that, there is a continuation of the same thing. From the body of the second cervical vertebrae, there is an extension of the posterior longitudinal ligament. And that extension also goes where? To the basilar part of occipital bone. This is called as a membrana tectoria. We talked about this membrana tectoria again in the embryology because this also is one of the remnant of notochord. Membrana tectoria. So this here is what? Membrana tectoria, or you can simply call it tectorial membrane. And again, the thing to be highlighted here is that membrana tectoria is what? It is a continuation of posterior longitudinal ligament. बस ये चीज नहीं बोलेंगे. Anterior atlanto-occipital membrane is a continuation of anterior longitudinal ligament. जबकि posterior longitudinal ligament it ends at the second cervical vertebrae, and after that from there till the basilar part of occipital bone, that membrane is called as a membrana tectoria. उसकी continuation. This here is the superior band. Now I have space, I can use the space here. That is called the superior band. This here is the inferior band of the cruciate ligament, right? And this is what ligament? This was a cut section through the transverse ligament. There is a cut section through the transverse ligament. If you understood this part, हमारा काम हो गया आज का जो main चीज थी. That is this diagram is the one which you got to understand the atlanto-occipital and the atlanto-axial joint, because all the discussion is in this now. Jaldi se quickly, let me recap this for you. In the meantime, rest will finish off the diagram. So let me start from here. That from the posterior arch of the atlas, to the margin of the occipital bone, or you can say margin of foramen magnum, there is a membrane behind called as posterior atlanto-occipital membrane between the atlas and occipital. Similarly, we have anterior atlanto-occipital membrane also, but that anterior atlanto-occipital membrane is basically a continuation of, or the cranial continuation of what ligament? Anterior longitudinal ligament of the vertebrae. We have a posterior longitudinal ligament also of the vertebrae, which continues behind as a membrana tectoria. From the dens, from the apex of the dens to the again margin of this basilar part, or to the basilar part of the occipital bone, we have a ligament called as apical. Now we have apical ligament of the dens, and then we have a ligament that is a crisscross ligament. And because this is a sagittal section, so you look at it like this. So you're looking at this part of transverse ligament here, and you are able to see the superior band and the inferior band like this. Because of sides से देख रहे हैं. सामने से देखेंगे तो ऐसा दिखेगा, पीछे से देखेंगे. So this image, I'm going to use it for discussion on both the joints. But one last detail which I need to add, one more ligament basically which I need to add, which I cannot show you in this image, that can be seen when you turn the picture like that, or you see it from the same section that I showed you guys, when you see it from the posterior side, by cutting the posterior arch of the atlas. If you're done with this diagram, take one last shot of the diagram, nothing much in there. Now let's say this is an occipital bone here, that is occipital condyles. Here is a margin of foramen magnum. So let's say this is the occipital condyles. Here is an atlas vertebrae. One side, there is an atlas vertebrae of the other side. We are focused at the second cervical vertebrae. Now this is the axis. When you see the axis, if you're able to see the entire axis vertebrae, this is with the dens. That's how the second cervical vertebrae roughly will look like, guys. My main focus is dens so that you can see this odontoid process. So basically, I've cut this arch. I've cut the arch so that I can clearly see the dens of the second cervical vertebrae. That is C2 vertebrae, right? That is C1 vertebrae. Okay, from the apex of the dens, we already said there's a ligament which is going to the margin of the foramen magnum. That is apical ligament. You already saw that. We are able to see this in the sagittal section. That is apical ligament. But there is another ligament which is coming basically from the sides like this. And again, it is flaring on the side to the margin of foramen magnum only. It's a very important ligament. It's from check ligament both. This ligament is called as the alar ligament. Alar ligament of dens. That was an apical ligament of dens. This is alar ligament of dens. This side में ऐसे पहला होता है. Alar ligament of dens. Cruciate, you already know it here. We have a transverse which is going from one C1 to another C1 like this. That is a transverse ligament, which is having a superior band. I'm not drawing the entire superior band, otherwise apical ligament will be hidden. And that is the inferior band. So that's a transverse ligament. This is inferior band, and there's a cut end of the superior band. Cut end of the superior band. Overall, पूरा cruciform ligament. If you have understood these two diagrams, let's complete this topic. So we're talking about the atlanto-occipital joint, and then we'll go to the atlanto-axial. So we already said atlanto-occipital joint. It's a simple joint. It is the joint which is present here. Atlanto-occipital joint. If I have to show in this diagram, it is between the C1 vertebrae and the occipital condyle. This one and this one. There is an atlanto-occipital joint. You can also do that. This is the atlanto. So if you look at both the images, atlanto-occipital joint obviously will be having its own capsule, but there is no as such supporting ligament here. कोई बहुत ऐसा कोई supporting ligament नहीं which is supporting this joint and so basically the supporting structure here are the membrane only. we have an anterior atlanto-occipital membrane and there is a posterior atlanto-occipital membrane. So that is the one which is forming a support system for the atlanto-occipital joint. So when it comes to the ligaments, we are writing about the ligaments of the atlanto-occipital joint. Ligaments in the capsule. Capsule is there. We have a fibrous capsule surrounding it. There is a fibrous capsule which surrounds this atlanto-occipital joint. And the one feature which you should remember, I mean, again, not a very important thing or to be written in the exam, but fibrous capsule, it is thick on the posterior lateral side and thin on the posterior medial side. The capsule is quite thick where posterior laterally, and it is thin posterior medial. What other support we have? Other ligamental support? Anterior atlanto-occipital membrane. Now, if I may ask you guys, atlanto-occipital membrane, where that ligament atlanto-occipital membrane was attached? You already drew the diagram. How about if I write just a quick note about it? Atlanto-occipital membrane was attached between what and what? It was attached below to what? To the anterior arch of the atlas and above to the anterior margin of foramen magnum. You can say basilar part of occipital bone. एक ही बात है. So this atlanto-occipital membrane, it is attached where? It is attached below to anterior arch of atlas. This is just for you to make the notes. Anterior arch of atlas and above to the anterior margin of foramen magnum. You can say anterior margin of foramen magnum, which is made up of the basilar part of occipital bone. एक ही बात. That was one support. Right? That was one support. Another support is from the posterior side, and that is what? That is posterior atlanto-occipital membrane. These supports are the only support which are helping the atlanto-occipital joint apart from capsule. कोई direct ligament नहीं होता उसका. These are membranes which are supporting it from the anterior and the posterior side. What about the attachment guys? Could you help me with the attachment here? Posterior atlanto-occipital membrane. Below it is attached to what? Upper part of the. It is attached below to what arch? To posterior arch of atlas. Same is totally the posterior arch of the atlas and above to posterior margin of foramen magnum. Posterior margin of foramen magnum. Posterior margin of foramen magnum. What about the blood supply and the nerve supply? That's the simplest thing to remember here, guys. The blood supply. What is the artery we discussed very in close relation to the first cervical vertebrae? The vertebral artery. So blood supply comes to the vertebral artery. Nerve supply is even simpler. What is the nerve running with the vertebral artery over the arch of the atlas? On the posterior arch of the atlas, the nerve which was running was the C1 nerve. The first cervical nerve is the nerve supply to this atlanto-occipital, and even to the atlanto-axial joint is the same only. A main चीज यहाँ पे जो question asked they will ask you that what are the movements possible? The movements of this joint. In which axis they will take place? And most importantly, what are the muscles responsible for it? And if you remember the diagram of the norma basalis, so we already know it. It's very simple for us now, guys. The movement, but what movements are possible at the atlanto-occipital joint? The movement present at the atlanto-occipital is a yes movement. Like this nodding movement, this is possible here, and the lateral flexion is possible. This is not. This no movement is at the atlanto-axial joint between the atlas and axis. We are talking about atlanto-occipital. So atlanto-occipital is for this movement, that is nodding movement, and also for the lateral flexion, sideways like this. So first here is the flexion and extension, which is nothing but the nodding movement. The nodding movement, which is used to say like yes. अगर आपको yes बोलना है, the nodding you will do like this. Nodding movement or yes movement. Axis. When my head is moving like this, it is basically what is the axis here? If the movement is in this plane, obviously we know that axis and plane are obviously perpendicular to each other. So axis has to be this one. So transverse axis. So when you do yes and no, and you say so yes like this, so it is through this axis. That is transverse axis. When you do the lateral flexion, then the axis is anterior posterior axis. That is axis and movement is taking place in this plane here. So the axis for the flexion and extension is the transverse. Okay. What muscle? Beta flexion and extension. Now, what muscle will be there for the flexion and what are for the extension? And I told you it is very simple. You just have to think about the muscle in front of the occipital condyle, behind the occipital condyle. In front of the occipital condyle, if you remember, the muscle were longus capitis and not longus muscle. Longus capitis and which one? Rectus capitis anterior. Rectus capitis anterior. Simple. Okay. What about extension? Extension, I told you, think of all the muscles which are present behind. The muscle present behind were rectus capitis posterior, which one? Both, major and minor. The medial side was minor, later was major, so major and minor both. Then what? Semi-spinalis capitis. I'll tell you something interesting about the semi-spinalis capitis. Splenius capitis. And if you remember, even the upper part of trapezius also. I've highlighted all those muscles to you and I'll send it immediately after the class here. So rectus capitis, posterior major minor, semi-spinalis capitis, splenius capitis and upper part of trapezius, they're all helping the extension. They're all behind the atlanto-occipital or occipital condyle. But इसमें एक ये जो muscle is the semi-spinalis capitis. It is a very special muscle for us. The reason is, you know, if you look at your head, if I turn my head to one side here, obviously posterior part is more or less flat here, but the anterior part we have extension. So that means the center of gravity of the head is not exactly in the middle. The center of gravity basically tends to make our head fall in front. अगर आप ऐसे बैठ बैठे सोए, if I sleep like this, my head will fall like this because the center of gravity is more anterior. The weight of the face is more on the anterior side of the head, and face is more on the anterior side. So obviously the head tend to fall forward here. So the muscle semispinalis capitis is the muscle when like normal day-to-day activity, your head is straight and your neck is straight, erected, and your head is eyes facing front. That is because of this muscle only. So this extension of the neck, this semispinalis capitis extensor of the neck, is the one which is responsible for the erect position of head. So this muscle is almost active all the time. This muscle is active all the time. It is the one which is keeping your head in the erect position like this. If this muscle is not working, then obviously your head will fall forward because of the center of gravity. Then this was one movement, but another movement is what? That is the second type of movement here is the lateral flexion, the side-to-side flexion. The another movement possible here is this lateral flexion is possible here. The axis is what axis? The anterior posterior axis. I already told you there is anterior posterior. The axis is like this, and around this axis only you can do this movement. This is the plane of the movement, and axis is always perpendicular. Anterior posterior axis. Muscle. What muscle on the side here? That was the here was simple. There is rectus capitis. Which one? Lateralis. Rectus capitis lateralis, which was lateral to the occipital condyle, is for the lateral flexion. So all I'm trying to say here is, when they ask the short note on the muscles on the atlanto-occipital joint, what I've seen is people, number one, they get stuck on the ligament here, and especially those ligaments which are connecting the tens to the upper part. So if you understood the diagram, it's pretty simple. And secondly, the most people actually get stuck in this part here, the muscles and the movement. Those don't try to remember the muscle directly. Look at the base of the skull, see where the muscles are attached, and automatically you will understand that what muscle will cause what. The second joint we're going to discuss here is atlanto-axial. Atlanto-axial joint. Just take 10-15 minutes more, guys. So I know that it's a long session, but still. Atlanto-axial joint. But atlanto-axial joint, first of all, there are two atlanto-axial joints. Whenever someone says atlanto-axial joint, we start thinking of dens and the axis and the the arch of the atlas. But side of the joint, if you look here, one joint is this obviously. But there's a joint here as well. This is also a joint now. So there are three atlanto-axial joints. One in the midline, we call it median atlanto-axial joint, and then two are on the side, we call them lateral atlanto-axial joint. So that is also there. Although that joint is simply a plain synovial joint. But atlanto-axial joints, we have one median तो वही होता है median atlanto-axial joint, and we have two lateral atlanto-axial joint. इसके बारे में कुछ डिस्कस नहीं करना है. Lateral atlanto-axial joint is simply a plain synovial joint. It's a plain synovial joint. Our main focus here is to that central joint, that is a median atlanto-axial joint. As a matter of fact, whatever is needed to be discussed there, we've done the most of the part there. But okay, let's understand here. If you look at the articular structures, for that I wanted to draw a little diagram with me here, guys. If I draw the atlas vertebrae for you, this is the anterior arch of the atlas. So no body there, right? There's no body. Anterior arch, posterior arch. The diagram is not great. Okay. This here is the odontoid process extending inside. We already know that's a dens or the odontoid process is there. And the ligament we already said about, talk about, guys, that is what ligament? That's a transverse ligament there. Please draw it with me. There is a transverse ligament. In the transverse section, that's how it is looking like. There is a transverse ligament. This is dens, of course. Dens or the odontoid process. So the joint we are talking about is this one here. Basically, the joint cavity can be divided in two parts. We have one joint cavity present in front. That is the anterior joint cavity, which is here. So there is basically a synovial lining in this region, and there is a joint cavity present here as well. So when I talk about the atlanto-axial joint, the median atlanto-axial joint, that joint, the articular structure can be divided, the articulation can be divided in two parts. The articulation can be divided in two parts. So in the median atlanto-axial joint, this here is the anterior articulation. There is an anterior articulation, and this anterior articulation is present between what and what? It is present between what? Between the anterior arch of atlas, and dens. Whereas this here is the posterior articulation. This here is the posterior articulation, and this posterior articulation is present between what and what? It is present between transverse ligament and again dens. So draw this diagram and please understand that the atlanto-axial joint, those joint cavity, it is divided in two parts. We have an anterior joint cavity and we have posterior joint cavity. Anteriorly the joint is between the arch and the dens, posteriorly the joint is between dens and the transverse ligament. Ligament, we have discussed all these ligaments, it's just that let's write them together here. The ligaments, the most important ligament here which is supporting the dens is obviously the transverse ligament. The most important ligament here is the transverse ligament. And I'm just making you write all these things so that you have your notes also along with the diagram. You don't have to go into the books and read it. And from the notes itself, you can see that what exactly and where the ligament is attached. Like transverse ligament, it is basically attached where? It is attached to what? It is attached to the lateral mass of the atlas. It is attached to the lateral mass. Each side it is attached to the lateral mass of atlas itself. It is attached to the lateral mass of atlas itself. We also know that this transverse ligament is having some extensions. Guys, what are the extensions? We have one extension called as what band? Superior band. And another extension, it was what? It was inferior band. The superior band and the inferior band. अगर मैं आपको वापस लेके जाऊँ superior band and inferior band पे, just look at this picture once again. Guys, superior band can't attach to superior band is attached to what? It is attached to the basilar part of occipital bone, and inferior band is attached to the body of axis, to the body. You can say posterior surface, or you can simply say to the body of axis. So again, for the notes purpose, you can write it down as well. That the two extension of transverse ligament, superior band, it was going above and attached to basilar part of occipital bone, and inferior band is attached to body of axis. And obviously we said that these bands, this superior band plus inferior band, I'm writing in short, but आप लिख लेना superior band plus inferior band plus transverse ligament. Superior band, inferior band, transverse ligament, they collectively are called as what? They are collectively called as a cruciform ligaments. So obviously the main support of this joint is this, that is the cruciform ligament, which is connecting the dens to which is basically holding the dens in its position here. But that was not the only ligament. We have other ligaments also which are connecting the axis to the occipital bone, like apical ligament. There was alar ligament was also there, and membrana tectoria is also there. So let's very quickly write about those as well. If you have that the hand drawn picture with you, let me write it this way, guys. Ligaments connecting what? Ligaments connecting the axis vertebrae, the second vertebrae, with what bone? With occipital bone. What other ligaments are connecting the second cervical vertebrae to the occipital bone? Jaldi se ek baar picture show kar deta hu, then I'll write about that also. And those were, here we go. One was apical ligament of dens. You can see from where to where it is apical ligament of dens. One is the anterior atlanto-occipital membrane is there. You can see membrana tectoria, which was a continuation of posterior longitudinal ligament. And in this diagram, you can see alar ligament is also there, which is going to the side and attached to the margin of foramen magnum, which is most important as well. So these are the ligaments which are connecting the axis vertebrae to the occipital bone. So we got number one, that is the apical ligament. Apical ligament कहाँ से कहाँ था? Apical ligament is from dens to the basilar part of occipital bone. लिखना, this is the remnant of notochord. Apical ligament and membrana tectoria, they both are the remnant of notochord. This is the remnant of notochord. Apical के अलावा there was an alar ligament, which is very very important. This alar ligament is from side of dens के side से ज़्यादा, from the side of dens to the tubercle. I'll show it to you. To the tubercle, just to the tubercle on the medial aspect of occipital condyle. This is important, guys. This is worth writing. I'll tell you why it is worth writing. From the side of the dens to the tubercle on the medial aspect of occipital condyle. Let me again show you the picture of the occipital condyle, and you can see they have a small projection toward the medial side, toward the foramen magnum inside. Well, not in this image, the previous one here. Can you see that? Look at this, guys. This projection here, where I'm putting an arrow right now here. These are the projections of the occipital condyle which are toward inside, and this is where the alar ligament will go and attach you. So alar ligament will come from the dens and will spread like this and attach to these tubercles which are present on the medial side of occipital condyle. Medial side of occipital condyle. This is the attachment of what ligament? The alar ligament. I told you that this ligament is important. This ligament it's very important because this ligament it is also known as the check ligament. That's why it is important. It is a check ligament because this ligament is bifurcating like this. So with the check ligament, it is not allowing the excessive rotation of the neck. There is a rotation of the neck. उसके बाद आप नहीं कर पाते. So excessive rotation and the flexion, it is checked by this ligament here. So this is called the check ligament, and it checks what? It checks excessive rotation and flexion. It checks the excessive rotation and the flexion. That's why we call it check ligament. And but number 3 which I'm writing here, that is membrana. That is membrana tectoria. Membrana tectoria. Just remember that it is the upward continuation of what ligament? Posterior longitudinal ligament. It is the upward continuation of posterior longitudinal ligament. It is upward continuation of posterior longitudinal ligament. And as I told you, that these two, the two which I'm highlighting for you, the apical ligament of dens and membrana tectoria, they both are developmentally, they both are the remnant of notochord. So very lastly, if I just take you back to this picture here, let me tell you a small clinical anatomy, and I can discuss it on this image itself. This is the second cervical vertebrae, guys. This is the second cervical vertebrae, C2 vertebrae, and this is the pedicle of the C2. If this pedicle is fractured, like ये भी fracture हो यहाँ से, हमारा ये भी fracture. If this pedicle is fractured, that fracture is called as a hangman's fracture. This is a sign for fracture. आपको नहीं मालूम हो तो this is a sign for the fracture. Hash is a sign for the fracture. This is a sign for dislocation. ये हम dislocation use करते हैं वाला sign, and we use hash for the fracture scene. So pedicle of second cervical vertebrae, C2 का जो pedicle है उसके fracture को हम बोलते हैं hangman's fracture. Bilateral fracture हुआ तो एक side पे नहीं, bilateral fracture of this is called as a hangman's fracture. You know hangman's fracture. We call it hangman's fracture because when you hang someone, that knot which we place here is placed in such a way that when a person actually falls and there's a rope around the neck, so that can basically lead to the fracture of this pedicle bilaterally. So we call it a hangman's fracture here. But I tell you something, death by hanging. When a person dies because of hanging, it's not because of this hangman's fracture. Even so, we call it hangman's fracture. So this is the fracture which is basically killing the person when somebody is sentenced to the death. That is because of, let me use that picture to explain you that. This one, look at this. If when a person, आपने एक चीज notice की होगी that when somebody gets to death, then they put a rope around their neck, that rope, and they usually open the floor so that the person will fall. So when the person will fall, there will be a very abrupt extension, and that very abrupt extension, that when there is a झटके से गिरेगा तो there is an abrupt extension, and that extension will rupture this ligament. You rupture this. If this ligament gets ruptured, what will be pushed anteriorly? This dens will be pushed anteriorly. This dens will come in front. Front नहीं है, actually posteriorly होना चाहिए. Dens moves backward, and if dens moves backward, it will compress lower part of middle oblongata. इतने ऊपर spinal cord नहीं होती. Spinal cord starts from C1 vertebrae. Dens is very much in the upper part, so it is basically facing the very lower part of the middle oblongata, and that lower part of the middle oblongata is having the vital center. So that indirectly lead to the compression of vital centers, the respiratory centers and all, and that's how the person dies when they are given the sentence of hand till death. So when they tie a knot in the neck, they open the floor, the person falls down, there's a abrupt extension. That extension will lead to the rupture of the transverse ligament. Transverse ligament rupture, the dens is not supported now. Now if the dens is not supported, posterior dens will move backward, and that will compress the lower part of the middle oblongata, and that's how those respiratory and the pneumotaxic apneustic areas in the cardiogenic center which are present in the lower medulla are compressed, and the person dies because of it. Discussing here is the suboccipital triangle. It's a triangle present at the back, so the name is suboccipital triangle. Well, to understand this triangle well, I need to draw a diagram in which you are viewing the base of the skull from the posterior aspect, and you're looking at the first and second cervical vertebrae also. So this goes like, imagine you're looking at the norma occipitalis. Up pictures you're seeing it from the posterior side. So there we go. This is the posterior view. Here we'll be having a mastoid process, and that will be the region of foramen magnum. Okay, so that's the occipital bone, you're seeing it from the posterior side. If this is the vertebral foramen, if this is a vertebral foramen of the first cervical vertebrae, let us say this is the transverse process. Here we have the transverse process, obviously the feature of the transverse process that they have foramen transverse area in it. So I hope you're understanding this view. You're looking at the base of the skull, basically the posterior part of the skull bone. So you're looking at the occipital bone, or you can say norma occipitalis, and below that you're looking at, obviously in this region somewhere will be the foramen magnum. This is the first cervical vertebrae, and then we have a second cervical vertebrae just below that. If I may draw the vertebral foramen for that also, and here we go. These are the transverse process of the second cervical vertebrae. You know the foramen transverse area is a feature of the cervical vertebrae from the first to sixth one. Seventh may not have it. So this is the view that we need to understand. And obviously when you look at the occipital bone at the back, if you'll see, you are also able to appreciate some lines called as nuchal lines. So this last time when we saw this picture, it was the base we were looking at. This time we are looking at from the posterior side. So obviously this is going to be the superior nuchal line here, and here is the inferior nuchal line. The superior nuchal and the inferior nuchal line. So I just wanted to quickly draw this thing, because most of the times the teacher, they will tell you the diagram to draw for the suboccipital triangle is a very schematic diagram. They just draw it in the lines and they show the boundaries. So we're not actually able to visualize how it will look like. That's why I discussed those muscles last time with you, and now I'm going to put those muscles in here, and we'll understand that how exactly they form a triangle. Guys, rectus capitis posterior, minor and major. Minor was more medially present and major was more laterally present. So here this is the inferior nuchal line. So from the and below the inferior nuchal line we have this muscle which is originating and inserting to the spinous process, or you can simply say posterior tubercle of the atlas. This is posterior tubercle of the atlas where it is inserted. That is a minor muscle. And just lateral to it, we have a muscle which is inserted to the spinous process of axis. Just draw it correctly. This topic is extremely simple. It's just about understanding the muscle orientation here. So this muscle is rectus capitis posterior minor, the smaller one, which is attached to the, you can see, posterior tubercle of the atlas. Whereas the muscle which is more laterally present here, this is rectus capitis posterior major, which is attached to the spinous process of the second cervical vertebrae, or you can say to the axis. That's the reason we call it major and minor. You can see it's a smaller one, some larger one. So it's rectus capitis posterior minor, and that's major. If you remember, there was another muscle which was between the superior and the inferior nuchal line. If you go back to your notes, you'll find out there was a muscle between the superior and the inferior nuchal line that was obliquus capitis, and we said superior. Obliquus capitis superior. Now today we'll see why we are calling it obliquus capitis superior. This obliquus capitis superior muscle will originate from here in between the superior and the inferior nuchal line, and will go obliquely, as the name says, obliquely, and it inserts to the transverse process of the atlas. Look at the lateral mass of the atlas, or you can say transverse process of the atlas. But this muscle here is obliquus capitis superior. And why are we not only calling it obliquus capitis? Why the word superior is there? Because there is another muscle called as obliquus capitis inferior, which is attached from the spinous process of axis to the transverse process of atlas. Look at that. It originate from the transverse process of the atlas and again going to the same insertion, that is to the spinous process of the axis vertebra, that is C1 and C2. If I provide it here, that is first cervical vertebra, that is the second cervical vertebra. If I may name these muscles very quickly for you, this here, try to label it this way so that we don't have to write the same thing again. This muscle here is the rectus capitis posterior. Which one? That is minor. You can see it's a small in size. Insertion is also to the posterior tubercle of the atlas, so it's a smaller muscle. Rectus capitis posterior minor. Whereas this muscle here is the rectus capitis posterior major. The triangle that we're talking about here is the one which I'm highlighting here. This triangle is called as the suboccipital triangle. Now, if let us say this is a suboccipital triangle, how the boundaries are named? This boundary is present on the superior medial side. That's superior medial. That is superior lateral, and then we have inferior boundary. Superior medial, superior lateral, and inferior boundary. So obviously these two muscles that we just labeled, rectus capitis posterior major and minor, are superior lateral boundary. They are forming the superior lateral wall. This muscle is what? That is obliquus. Obliquus, again capitis, and it is superior. There are two of them. This is obliquus capitis superior, and if I label this also along with that is obliquus capitis inferior. That is obliquus capitis inferior. So what boundaries are they forming? Obliquus capitis superior, as you can say, it is forming the superior. Sorry, that is not superior lateral, guys. Somehow my tablet is troubling me a little. It is superior medial, but I'm sorry. That is superior medial. That is present on the medial side. That's the superior medial. This one is superior lateral. This one is superior lateral. Superior medial, superior lateral, and obliquus capitis inferior is the inferior boundary. It is simply the inferior boundary. So these are three boundaries of suboccipital triangle. Boundaries of suboccipital triangle. Honestly, you don't have to know too much about these muscles. If you don't remember that what is the origin, what is the insertion of these muscles, that will definitely not affect your preparation in any ways. I told you in very much in the beginning of the head and neck only that the pre and paravertebral muscles, except the scalene muscles, are not very important to remember. So if you just know the name of the muscle, that is still good enough here. But for this topic, for the suboccipital triangle, which again is not a very important topic, we are at the end of the head and neck, so we are just doing the remaining part. So this is not a very important triangle to us, but let's say if they ask you this triangle about, then you got to know the attachment and then only you kind of remember it here. So this is about the boundary, guys, the boundary of the suboccipital triangle. Okay, after the boundary, the next thing here is the roof. What about the roof of the suboccipital triangle? The roof of the suboccipital triangle is by the dense fibrous tissue is present on this, and we have a couple of muscles present over there, out of which one muscle that you should remember is semi-spinalis capitis muscle. So roof is by the fibrous septum. There is a fibrous septum forming the roof, and this fibrous septum is covered by a muscle called as semi-spinalis capitis. I hope you remember this muscle, guys. Semi-spinalis capitis muscle, one of the muscle forming the floor of the posterior triangle. That's the point here. It is forming the floor of the posterior triangle, but here it is present in the roof of the suboccipital triangle. It is the roof of suboccipital triangle, and the more it goes downward here, it comes into the floor of the posterior triangle. इसको ऐसे याद रखते हैं. Semi-spinalis capitis, it is in the roof of suboccipital triangle and the fourth floor of occipital triangle. Now, out of the occipital triangle and suboccipital triangle, which one is higher? Which one is higher? The suboccipital is higher. So, जो triangle ऊपर है, the triangle which is above is close to the roof. So, for the suboccipital triangle, this muscle is forming the roof. The triangle which is below and on the side is occipital triangle, for which it is forming the floor. Semi-spinalis capitis is forming the roof of suboccipital and floor of posterior triangle, or you can say floor of occipital triangle. Floor, what is the floor for this triangle here? Now, floor can be understood by looking at this diagram carefully. Now, what you can see in this floor, guys, you can see the posterior arch of the atlas. Look at my pointer here. That is the posterior arch of the atlas, which is forming the floor. And you also know from the posterior arch of the atlas to the posterior margin of foramen magnum, there was a membrane we discussed last time, and that membrane was posterior atlanto-occipital membrane. So those are the two things on the floor. One, you can clearly see the bony thing is what? That is the posterior arch of the atlas. We got posterior arch of atlas. One, and the second thing, again coming from the same posterior arch of the atlas and going to the margin of foramen magnum, upper little child, that is what? Posterior atlanto-occipital membrane. Posterior atlanto-occipital membrane, that is there in the globe. So that is suboccipital triangle about the boundaries of this: superior medial, superior lateral, inferior, the floor and the roof. Finally, just to write down, and you don't have to draw those things, that is the contents. What content we expect to see in this triangle here? Now, let me tell you guys, the content that you expect to see here, please don't draw it. Don't draw it. I'm just drawing it for your understanding. If you draw it, your diagram will become a bit too much of cluttering in there. You know that vertebral artery will come out from this foramen transversarium, and that vertebral artery I told you goes on the posterior arch of the atlas like this. A third part of vertebral artery, and the nerve which will be coming out from here was first cervical nerve. This is something we discussed last time also, that when you look at the posterior arch of the atlas, the two structures which are running over the posterior arch of the atlas is the third part of vertebral artery, which is basically going above into foramen magnum, and the nerve coming out from there is a dorsal ramus of first cervical nerve, or simply you can say first cervical nerve. C1 nerve will come out from there. Both are the contents. So from the content point of view, we have third part of vertebral artery. Third part of vertebral artery, we got dorsal ramus of C1 nerve, dorsal ramus of C1 nerve, and one more content which you can add. There is a venous plexus also present in there. We call it a suboccipital venous plexus. Not very important thing to remember, but still, because it is there, so you should remember. There is a venous plexus in that region called the suboccipital venous plexus is there. So that is all about the suboccipital triangle. Let's say this is a very short note question. Probably it doesn't deserve to be asked for more than 3 marks or maximum 4 marks. So just draw the diagram, tell about the boundaries, roof, floor, and the content here. I repeat one thing, because when you revise the whole thing together, there could be some confusion here. आपको एक चीज याद दिलाता हूँ, guys. Occipital triangle and suboccipital triangle. When I talk about the muscle that is semi-spinalis capitis, semi-spinalis capitis is in the roof of suboccipital and in the floor of occipital triangle. But when you think of an occipital artery. Occipital artery was running where? Occipital artery was the content of occipital triangle. And that occipital artery will go behind, and sometimes that occipital artery can be seen running in the roof also. Here, apart from the semi-spinous capitis, you might see the occipital artery also coming in, present in the roof. I didn't write it because it is not mentioned everywhere, but occipital artery can be seen in the roof of the suboccipital triangle. Suboccipital triangle का roof हो सकता है, वो content नहीं है. Occipital artery was the content of occipital triangle, that is the posterior triangle. Okay, that is the one thing that we got to discuss here. That is this triangle, that is suboccipital triangle. Now moving on, the next topic we need to look at here is the cervical plexus. Another leftover topic is cervical plexus. So you will realize why I didn't discuss the cervical plexus earlier. First of all, understand it's not a very meticulous plexus like the brachial plexus or the lumbar plexus is. It's a little confusing. I mean, one diagram probably is not sufficient to make you understand everything about the cervical plexus. So I usually go with the two separate diagrams here. So there are a few things to understand, and then in your exam also you definitely can draw two separate diagrams for the cervical plexus, in which one you can show the superficial nerves, the cutaneous nerve, and in another one you can show the communicating and the muscular branches. So definitely you can also draw the two diagrams, but there are a few things before we start with those nerves. First of all, the cervical plexus, when we talk about it is formed by the ventral rami of C1 to C4 nerves. Although I will show you C1 to C5 nerves, because fifth nerve, although it is not forming a part of plexus, but there are some important nerves which are coming from C5 as well. But when we say cervical plexus, C1 to C4 nerves, the first four cervical nerves are contributing to the formation of cervical plexus. Now these rami that we're looking at here, these rami comes out between scalenus anterior and medius. And I think we don't have to discuss this thing again. We have already talked about it in the deep cervical fascia also. When we saw the transverse section, we saw that the transverse process gives rise to the scalenus anterior, scalenus medius, and scalenus posterior muscle. In the lower part between the scalenus anterior and scalenus medius, brachial plexus comes out. If you go in the upper part, the cervical plexus comes out. So same two muscle guys. I don't draw it, because I'm going to draw it very quickly and rub it off. Just to tell you that if this was the transverse process, and we have the scalenus anterior muscle here, the scalenus medius here, and scalenus posterior fascia also. When we saw the transverse section, we saw that the transverse process gives rise to the scalenus anterior, scalenus medius, and scalenus posterior muscle. In the lower part between the scalenus anterior and scalenus medius, brachial plexus comes out. If you go in the upper part, the cervical plexus comes out. So same two muscle guys. I don't draw it, because I'm going to draw it very quickly and rub it off. Just to tell you that if this was the transverse process, and we have the scalenus anterior muscle here, the scalenus medius here, and scalenus posterior here. So obviously in between the scalenus anterior and medius, whether it is cervical plexus or brachial plexus, they are coming out between the scalenus anterior and scalenus medius muscle. Cervical plexus as well as the brachial plexus. So that's how exactly they are leaving the neck. But there is one special feature of the cervical plexus, that all these nerves, C1, C2, C3, C4, they basically communicate with each other also. Like C1, when the C1 nerve comes out, it gives off upper branch and lower branch. C3 is coming out, giving off upper branch and lower branch. And these upper branch, lower branch, they will communicate with each other also. So they form a loop. That is why this plexus is also called as a plexus of loops. This plexus, cervical plexus, is also called as it is also known as plexus of loops. And that's why it's not very easy when you look at the picture of a cervical plexus, any of the atlas, whether it is Netter's or Cunningham, whatever atlas if you're using, it's not really easy to judge that what nerve is coming out from where, because there are so many branches coming out of there, and moreover we have loops also between the nerves. So let me just try to make it a little simpler for you. So we said the nerves which are forming cervical plexus, let's say this is C1, this is C2, the C3, and the C4. And as I said, we will talk about C5 also, but let's stick to this. So C2, C3, C4, and I'm just drawing C5 here, although I'm not. These are not the vertebrae. Please understand, I'm not drawing these. Don't look at these boxes as a vertebrae. I'm saying nerve segments. C1 nerve, C2 nerve, C3 nerve, C4, C5 nerves. What happens is, C1, when the C1 nerve comes out, it is not having an upper division. Because the rest of the nerves can have an upper division, lower division, upper division, lower division, upper division, lower division. But C1 nerve is not having an upper division. It is only having a lower division. Look at this. If let's say in this picture, if this is the anterior side, let me write it on this side here. If this is the anterior side of this image, I have to write it that far, and this is the posterior side of this image. So basically, seeing it from the side, anterior side and posterior side. Now, side se dekh rahe hain, that's the anterior and the posterior side. We only have to simply say there's a branch coming from C1, that is a ventral rami coming from C1, and the ventral rami coming from C2 is having an upper branch, and the lower branch is also there, but lower branch is not on this side. Let me just draw this and then I'll make you understand this. This here is nothing but the transverse process of atlas. Transverse process of atlas. The loop which is formed between the C1 and C2 nerve, as I said, all these nerves will form the loop with each other, but the loop which is formed between the C1 and C2 nerve is present anteriorly. It is present toward the anterior side, and it goes in front of the transverse process of the atlas. Transverse process of the atlas. You already seen the atlas vertebrae, it is having a transverse process, so in front you will see it. The rest of the loop are present on the posterior side, like this. C5 is not forming the part of the cervical plexus, so first thing to understand here, that's why we call it the plexus of loops, but the first loop is present anteriorly, the second and third loop are present posteriorly. So these basically are just the communication between the ventral branch of C1, ventral branch of C2, but anteriorly here, ventral branch of C2, ventral branch of C3, ventral branch of C3, ventral branch of C4, but on the posterior side. So these are three loops that you will notice in the cervical plexus. That's why we call it the plexus of loops. One thing. So one is anterior and the rest two are posterior. Okay. Now we said the branches which are coming out of this cervical plexus, there are two types of branches. We have cutaneous branches, and you already know about the cutaneous branches. I just have to show you the origin, and then we have some deep branches. So when we talk about branches, I'll use the diagram, but let me just first tell you that how we're going to approach it. The branches of the cervical plexus are, we got a superficial branches. We can call them cutaneous branches, also superficial or cutaneous branches, and then we have deep branches. Deep branches are the ones which are supplying the muscles and forming the communicating branch with a sympathetic chain. So superficial branches and the deep branches. Okay. Let me just focus on this part first, guys. Let me focus on the superficial branches first. Okay. Let me take you back to in your memory lane, guys. In the posterior triangle of the neck, in the roof of the posterior triangle of neck, we discussed in detail about the 4 cutaneous nerves which were seen coming out of the nerve point. Those nerves, one was a transverse cutaneous nerve of neck, great auricular nerve, lesser occipital nerve, supraclavicular nerve. I hope you remember those 4 branches, the 4 cutaneous branches. Those are the 4 superficial branches we have in here. Which 4? If I just name them for you first, the 4 branches in there, the 4 superficial branches there are, we have great auricular nerve. The root value is C2 and C3. I could show the root value directly on the diagram, but you can write down if you want. Then we have the nerve that is lesser occipital nerve. Just think about the nerves we discussed in the roof of posterior triangle. Lesser occipital nerve, the root value is just C2. We have transverse cutaneous nerve of neck, or you can call it anterior cutaneous nerve of neck, which is also having a root value of C2 and C3. And supraclavicular nerves. The supraclavicular nerve, remember the nerve which divides into 3 branches, the supraclavicular nerves, which is all having a root value of C3 and C4, and sometimes C5 also, C3 and C4, sometimes C5 also. So these are the 4 superficial branches will be coming out of the cervical plexus. But to show you the diagram how exactly to draw them schematically correct as well, let me go here. Okay, first guys, the nerve that you see coming out of the C2, and I'm just using a different color to denote the nerves. You make sure you don't use a different color, guys. Don't use just a black color or a yellow color to show the nerves. Don't go with the red or blue, otherwise the diagram will be considered incorrect. So the nerve that is coming from C2 here, this here is the lesser occipital nerve. You can see it is the root value C2 itself. From the loop of C2 and C3, look at this. That's a loop of C2 and C3. The nerve which will go above and supply the lobule of the ear. That was the great auricular nerve coming from C2 C3. You can see it is coming from the loop of the C2 and C3. From the same loop of C2 and C3, the nerve which runs transversely in the neck, that was a transverse cutaneous nerve of neck. TCNN, that is transverse cutaneous nerve of neck. And the one which is coming from the loop of C3 and C4 and dividing into 3 branches. What nerve was that? That was a supraclavicular nerve. So guys, these are the 4 cutaneous branches which you will see, or superficial branches coming from the cervical plexus. I recommend you to try to draw it this way only, because that tells you the correct direction of how the nerves are running. We cannot see these nerves' origin because they are all covered with the sternocleidomastoid. When we dissect it, when we look at the content of the roof of the posterior triangle, the sternocleidomastoid muscle is covering it all up. Once you remove the sternocleidomastoid, then you are able to see the cervical plexus branches coming out. Although still it is not very easy to differentiate those branches easily. So remember that's how the nerves comes out. Great auricular nerve, lesser occipital nerve, transverse cutaneous nerve of neck, and supraclavicular nerve. Great auricular nerve coming from C2, C3 loop, say, also the transverse cutaneous nerve of neck. From the C3, C4 loop, the supraclavicular nerve will come out, and lesser occipital nerve is only coming out of the C2, ventral ramus of C2. And I tell you, when you look at this picture in VD Chorosia or in few other books, they have drawn the deep branches along with it. Now it becomes very difficult if I draw these nerves also and the deep branches along with it. It's a bit difficult to differentiate them. So I'm not going to do that. This is one diagram that we have in which we show that how the loops are there in between in this cervical plexus. And now we'll be looking at the deep branches. But first, let me tell you that what are the deep branches and which one are important to be remembered separately. Well guys, when you look at the deep branches, there are 2 types of deep branches you will see. Some are called as the communicating branches. So we have communicating branches. What are these communicating branches? They are grey rami communicants from the superior cervical ganglion. I don't know how many of you watched that video which I recommended you from my YouTube channel to watch for the grey and the white ramus communicants. If you have not, let me just give you a very quick recap of that information. But from the spinal cord, you don't have to draw this is just for your understanding. From the spinal cord, here is a lateral horn. Lateral horn is present only where the sympathetic nerves or the parasympathetic nerves are coming on. That is a lateral horn. We have a dorsal ramus. We have a ventral ramus like this. And then we have nerve going, and then you will see a sympathetic ganglion is present. This is a sympathetic ganglion. This is a sympathetic ganglion. I'm just looking at one sympathetic ganglion as of now. Now, as a general consideration, see what happens is, generally what happens is, and I'm going to rub this part, that sympathetic nerve, preganglionic sympathetic nerves will start from the lateral horn, will go in this ventral root, will go more distally, enters into the sympathetic ganglion, and relay there. It relay there in the sympathetic ganglion. One. And from there, the post-ganglionic sympathetic nerve will start, which will use this root which is more proximally present, and then it will go and supply the target horn. It will go and supply the target horn. This communicants which is in there, guys, this is called as a white ramus communicants, and this is a grey ramus communicants. There's a white ramus communicants and there's a grey ramus communicants. But a white ramus communicants is basically allowing the nerve to enter inside the sympathetic chain, and the grey ramus communicants, which is more proximally present or more medially present, you can say, is allowing the nerve to go out here. Point is, we are talking about the cervical plexus. Cervical plexus means cervical nerves, and cervical nerves are not sympathetic. If cervical nerves are not sympathetic, that means preganglionic nerve is not coming from the cervical part of spinal cord. Your first sympathetic nerve comes from T1, isn't it? Your first sympathetic nerve comes from T1. What is sympathetic outflow, guys? T1 to L2. The nerve coming from T1 to L2 region, those nerves are sympathetic, not above that, not below that. So it's the responsibility of the T1 nerve to go above and then go into the sympathetic chain and come out here. My point here is, if this is the thoracic part of the spinal cord, then this makes sense. We have a white ramus communicans and we have gray ramus communicans. But if you are looking at the sympathetic chain, or if you're talking about the sympathetic nerve or the spinal nerves of the cervical region, तो बेटा white ramus communicans तो होगा ही ना, because the nerves are coming from below. If this here is the spinal cord, here is the cervical sympathetic ganglion, let's say. So preganglionic T1 nerve will enter from here like this, and it will travel through the sympathetic chain only, and that will going to relay in the superior cervical or whichever ganglion it is. And the only thing you will see is the efferent coming out of the sympathetic ganglion in the cervical region. That means the cervical part of the spinal cord, which is somewhere here, is not contributing into the sympathetic chain. It is not. Preganglionic fibers are coming from where? From the T1 only. They will come from the T1. They ascend in the sympathetic chain, reaches the superior cervical or middle cervical, whatever ganglion, and from there only the nerve will come out. Sympathetic ganglion that you will see present in the cervical region, that will only give the fibers going out. Nothing is coming into it from the cervical part of spinal cord. That's why only what we have just gray ramus communicans. So you will be seeing gray ramus communicans. That is, this part will not be there in the. This part will not be there. It is coming somewhere from below and relaying like this, and only gray ramus communicans will be seen when you look at the cervical part of the spinal cord. So when I say communicating branches, I'm talking about what? I'm only talking about the gray rami. I'm talking about the gray rami communicans. Gray rami communicans from superior cervical ganglion. There are three ganglions in the neck region. That is also our topic for the day. We'll talk about the sympathetic chain in the neck. So we have three ganglions in the neck region: superior, middle, inferior. Superior cervical ganglion is giving off the gray rami communicans. Superior cervical is giving the gray ramus communicants, which will communicate with the first four cervical nerves. Right? That is about the communicating branch. One type. What are the other type of deep branches? The other type of deep branches are the muscular branches. Muscular branches. Muscles are supplied by some branches coming directly from there. Now, a lot of muscles, there is a lot of pre and paravertebral muscle. Again, I am not asking you to remember all these muscles, but just to go with it, the muscles like the rectus capitis anterior, muscle like rectus capitis lateralis, longus capitis. Remember that muscle longus capitis? It was very close to the rectus capitis anterior, longus capitis, longus colli muscle also. Let me go just with the important one, that is strap muscles. That's important. And I'm sure you all know about the strap muscles. What are the strap muscles? It's the one which are present below the hyoid bone in the midline. Sternothyroid, sternothyroid, all those strap muscles, the one which are present in the midline. So strap muscles, and strap muscle supply usually come from C1 to C3. Majority of the strap muscles they are supplied by the C1 to C3 because strap muscles are supplied by the ansa cervicalis, and ansa cervicalis is found by C1, C2, and C3. I'll draw that for you. I'm just telling you the branches for now. Then another important muscle I would say is the sternocleidomastoid and the trapezius. Sternocleidomastoid and trapezius, they are supplied by spinal accessory nerve. Fine, we know that. But guys, spinal accessory nerve is a motor nerve. Proprioceptive information from the sternocleidomastoid and trapezius is carried by the cervical plexus only. Like sternocleidomastoid, it is by the C2 nerve, and trapezius, it is by the C3, C4. Then we got scalene muscles. The scalene muscles are also supplied by the cervical plexus. Again, the root value is not important at all. And diaphragm. Diaphragm has a partial contribution by the cervical plexus because cervical plexus is made up of C1 to C4. Diaphragm is supplied by C3, C4, and C5 also. So diaphragm supply comes from C3, C4, and C5. So like these are like lot of deep branches which are contributing or which are coming out of the cervical plexus. Okay, let me put it in a diagram. Let me just put it in a diagram here. See what I'm saying is, guys, let me just take all the important branches from here. Common thing that you will see in this diagram and the diagram that we're going to draw is, but C1, C2, C3, C4, C5, again I have to put it the same way. I have to show this loop, and this loop again. But I'm not going to draw the superficial branches this time. I will only focus on some deep branches and the communication with some major cranial nerves. C1, C2, C3, C4, and C5. Let me go with those loops here. This is the one which is present anteriorly, and these are the two which are present posteriorly. Right? I hope this is clear to everyone how it works. That was the transverse process of atlas. Well, deep branches, let me just go with this one here. We all know that sternocleidomastoid and trapezius are supplied by the spinal accessory nerve. So like, let's say this is the spinal accessory nerve which is going to supply the sternocleidomastoid and trapezius. This is the spinal accessory nerve coming from the cranial cavity from jugular foramen, right? That is spinal accessory nerve. From C2 and C3 and C4, some of the branches will also supply the sternocleidomastoid and trapezius. Sometimes those branches are seen as individual branches. Kabhi-kabhi aapko posterior triangle you see them, those branches running separately. And sometimes those branches, they join with the spinal accessory nerve and they reach those respective muscles. So anything is possible. Like, you will have a communicating branch coming from C2. This branch is coming from C2 and this is going to carry the proprioception from sternocleidomastoid. It is coming from C2 and it is for the proprioception from sternocleidomastoid. Similarly, from the loop of C3 and C4, that means C3 and C4, we have another nerve which is joining in here. That is to which muscle? To the trapezius, coming from C3 and C4. So what I'm trying to say, please understand that when you look at the posterior triangle, you will see spinal accessory nerve there. You may see C2 nerve over there. You may see C3, C4 nerve also present there. May. But ये भी possibility है, you will only see spinal accessory nerve and C2 and C3, C4 will just join with the spinal accessory nerve and they will reach the respective muscle. Right? So again, I repeat that sternocleidomastoid trapezius, these are the proprioceptive nerve guys. Whatever I drew in the red color here, these are the muscular branches. They are supplying the muscles, but they are just carrying proprioception from sternocleidomastoid and trapezius. Another thing which we have discussed, these are just the previous thing that we discussed already. We are coming back to this one thing. Hypoglossal nerve. We talked about this. Hypoglossal nerve, it receives a communication from C1. Hypoglossal nerve, it receives a communication from C1. C1 nerve, using the hypoglossal nerve, it supplies two muscles, if you remember. Which two muscles? One was geniohyoid and one was the strap muscle, that was thyrohyoid. In fact, thyrohyoid, we said, is the only strap muscle supplied by the C1 using hypoglossal nerve. Well, there are a lot of branches coming from C1. other lot of other branches coming from C1 which are supplying the muscles like rectus capitis muscle. I'm least bothered about them, just writing like rectus capitis muscle, whatever it is, anterior, lateral, posterior. So they are, most of them are supplied by the C1. So rectus capitis muscles are supplied by the C1 also. My main focus here is to this communicating branch, not communicating I should say, to the branch which is joining the hypoglossal nerve, and using the hypoglossal nerve is going to supply geniohyoid and thyroid. We've also discussed that, again it's a previous discussion only guys, that there's a descending branch coming from this C1 called as descendens hypoglossi, and we have C2 and C3 branches which are also giving a descending branch called as descendens cervicalis, and together they form ansa cervicalis. This is descendens hypoglossi. Although it is coming from where? It is coming from the C1 nerve, but क्योंकि hypoglossal nerve के region से आ रहा है, so we call it descendens hypoglossi. This is descendens cervicalis. I really hope you remember all that. And then we know that they are supplying what muscle? They are supplying the strap muscle except one, and that one is what? Thyroid is already supplied there. So what are the remaining strap muscles to be supplied by this ansa cervicalis? It is supplying the superior belly of omohyoid, inferior belly of omohyoid. It supplies sternothyroid, and it also supplies the sternohyoid. If you want to write the full form, it's up to you. Superior belly of omohyoid, inferior belly of omohyoid, sternothyroid, and sternohyoid. So all the strap muscles are taken care of, except the thyroid are taken care of by the ansa cervicalis. This loop is the ansa cervicalis. Right, beta? And just one more nerve which I'm just marking here, the nerve which is coming from C3, C4, but because it is getting a contribution from C5, so I should not say that it is completely coming from cervical plexus. And that important nerve is the phrenic. That is the phrenic. This is all you have to describe if you get a question on the cervical plexus, which is, honestly speaking, less likely to be asked. When it comes to plexus, there is no more famous plexus than brachial plexus, or you would say the lumbar plexus. I would rate that at second. Sacral plexus, I would rate that as third, and cervical plexus, I would rate it as fourth. So the probability, from exam point of view, the probability of asking the questions are most on the brachial plexus and least on the cervical plexus. Lumbar plexus, sacral plexus, somewhere in middle. Right, so just make sure guys, you also try to draw the two separate diagrams, because imagine if I draw the same thing exactly in the previous diagram I have showing the superficial branches, it becomes too cluttered. It will be very difficult to identify the branches individually. So just explain in your answer that you are showing the superficial branches in one and you're showing the deep branches in the other one. So if you're done with this, let's move on. Another topic that we're going to take care of here is, we'll talk about some muscles, the two very, very important muscles on which you do get separate, a short note kind of question. That is, one is the orbicularis oculi muscle, because orbicularis oculi muscle is having three parts, and to understand that muscle, we also got to understand a little bit about the plate, the tarsus that we have, the tarsi we have in it. And the second important muscle is the buccinator muscle, again having three different fibers, and the middle fiber are interlacing, so it becomes an important muscle to be discussed. I told you in the beginning of probably the first or second day of our head and neck lectures, that what you got to remember for the muscle of facial expressions and what expression they are giving. And that too is just a viva question, guys. I mean, you cannot expect anyone to ask you a question on the muscle of facial expression and what expression they are giving. No, nobody's going to ask that. It's a more of viva question. It's more of a dissection viva question, that they will point out the muscle, what muscle is here, which muscle is, or maybe a kind viva question. Otherwise, from the theory point of view, from the theoretical exam point of view, the detailed attachment of the two muscle, and just two muscle from the facial expression, you got to remember, is orbicularis oculi and the buccinator. And that's what I'm going to discuss with you as well. I'm going to start my discussion with the orbicularis oculi. Before I write about the origin, insertion and all that, okay, first let's understand that upper eyelid and lower eyelid, they also have a very dense fibrous tissue present in these upper and the lower eyelid, which is providing a skeletal framework to the eyelid. Eyelid is not just a skin which is hanging around the neck. Eyelids are also, if you hold this eyelid, you can feel that there is something solid, there is something tough tissue which is present inside these eyelids here. And that connective tissue, it's a dense connective tissue which is present in the upper as well as lower eyelid, is called as a tarsal plates. We call them tarsus or the tarsal plates, superior tarsus and the inferior tarsus. Now let me explain you a little about it here. Guys, imagine if this is an orbit here. I'm not discussing the muscle as of now, I'm just telling you about this. That's the orbit here and this is the lateral side. If you remember, on the lateral side of the orbit, there was a tubercle present on the zygomatic bone. We call it a Wittnall's tubercle. Wittnall's tubercle or zygomatic tubercle, we have discussed it, I hope you remember it. We've discussed the Wittnall's tubercle which is present on the lateral side of the orbital wall. Medial side, obviously there is a lacrimal sac which is present here, and there is a lacrimal crest also. I'm not bothered about the lacrimal crest as of now, but obviously that is the lateral side of this image. And this here is a medial side, that's toward the nose, that's a medial side. Now what I said, there is a connective tissue, a dense fibrous connective tissue which is present in the upper and the lower eyelid, which is called as the superior tarsus and the inferior tarsus. So tarsus, plate we bolte. Now let's say it is something like, if this is a palpebral fissure, if this is the opening of the space in between, there is palpebral fissure. So this plate here is called the superior tarsus. It's important to understand this before we talk about the muscle, because the origin and insertion are having these terminology in it. That is superior tarsus. This is inferior tarsus. I told you what is tarsus, but a tarsus or tarsi. Plural is tarsi. Let me just write it on the side here. The plural is tarsi. Tarsi is a fibrous connective tissue which gives skeletal framework to eyelids. Upper eyelid, lower eyelid, which skeletal framework is by this fibrous connective tissue, which is called as superior and inferior. So one is the upper eyelid and one is the lower eyelid, right? Okay. Attachment of the superior and the inferior tarsus, lateral medial, that is important here. On the medial side, it is attached to the bone here. That bone is in front of the lacrimal sac, that is present to the frontal process of the maxilla here. This ligament, the name of the ligament is important, guys. This ligament here is called as a medial, or it's on the medial side, medial palpebral ligament. The name is medial palpebral ligament, which is attached to the zygomatic bone, the frontal process of zygomatic bone here. And the one which is attached to on this side here, frontal process of maxilla, I'm sorry, not the zygomatic bone, medial side में zygomatic नहीं maxilla आता है, frontal process of the maxilla which is going above here, which is giving attachment to medial palpebral ligament. And this one here is called as the lateral palpebral. Don't call it ligament, that is called as a raphe. You know why we call it raphe? Because raphe usually is given name to the point where the muscles are coming from both the side and inserting here. So this is going to be the point of insertions of some muscle that we will discuss. That's how we call it raphe. This is a ligament here. That's a ligament here on the lateral side. Remember, don't call it ligament. We call it lateral palpebral raphe. Lateral palpebral raphe, which is attached to what? Which is attached to the vitrinal tubercle. This is a bit about what do you say, the tarsus, the plate which is present in the upper and the lower eyelid. If you want to understand this orbicularis oculi muscle, you have to remember that what is medial palpebral ligament, what is lateral palpebral raphe, what is superior tarsus, what is inferior tarsus, and then only you can understand the muscle. If you're done with this, guys, let me just tell you about the muscle, and I'll draw a very schematic diagram also along with it. Okay, we'll keep drawing it as well. As I said, the muscle, and so how about we start with the same thing? What we have with us is upper eyelid, lower eyelid, which is space, and that is just the opening of the eye you're looking at. This on the side here, what is that? That is the raphe, lateral palpebral raphe, and here is the medial palpebral ligament. So I have to write this again. So we use this diagram to understand this attachment here. But the orbicularis oculi muscle is having three parts. One part is called as the orbital part. The outer ring is basically orbital part. The inner ring is called as the palpebral part, and the more inside, that is the lacrimal part. So we have three parts here. The palpebral part, outer one is orbital part, then palpebral part, which is actually in the eyelid, basically to eyelid, and the more inside, we have the lacrimal part also. That's the lacrimal part as well. Remember lacrimal sac where the lacrimal, what do you say, when we discuss the, this lacrimal apparatus, you'll understand what lacrimal sac is. Lacrimal sac is present behind this medial palpebral ligament. That's the lacrimal sac. I will discuss this lacrimal sac in the next topic after this, the lacrimal apparatus. That's lacrimal sac, which is present behind medial palpebral ligament. Okay. So talking about the muscle, guys, the muscle we said, if I talk about the muscle orbicularis oculi, we said one of the part of this muscle is, what part? That is the orbital part. What is the origin of the orbital part? I'm writing O for the origin. The origin of the orbital part is this medial palpebral ligament only. But which part? Is it the medial part or lateral part? It's the medial part. Remember, this is the medial side. This is the medial side. So it is coming from the medial part of medial palpebral ligament like this. The origin like this. It makes a concentric ring around the eye and come back to the same point. That's the outermost circle you're talking about. That's the first part of this muscle. Its origin is from where? Very precisely, origin is from the medial part of medial palpebral ligament. Medial part of medial palpebral ligament. And insertion, it makes concentric ring. It makes concentric ring and insert to the same point where it is originated. Insert to the same point where it is originated. So the first part, orbital part, which is coming from the medial part of medial palpebral ligament, will encircle around the orbit here, and then will go to the same medial part of medial palpebral ligament. That is what this orbital part is. This being the outermost part, this portion is the one which saves your eye from the wind and all. When you have too much of sunlight, then you basically not only using your the sphincter pupillae muscle and all, you're also using the orbital. Have you seen that when you come out in the sun, then you just do like this. You try to stop excessive light coming inside here. Or in other words, the best way to describe the action of this muscle is the forceful contraction or the hard contraction. The tight closure of the eye is done by this muscle. When you tightly close your eye, you can see the wrinkling around the eye here. Very tightly close your eyes. That is done by this muscle here. So the action, I'm writing ACT, that is for the action. Action is the tight closure of the eye. Tight closure of eyelids, I should say more correct. What part is that? That is the orbital part. Sabse bahar wala, that is orbital part. Okay. Coming to the second part, I'm just trying to use a different color so that you have no confusion regarding the muscle, how it is originating. But the second part is called as the palpebral part. What is the palpebral part and how it goes? Palpebral part, it takes origin from the lateral part of the medial palpebral ligament. Lateral part of medial palpebral ligament like this. And insert, you can see where? To the raphe, to the lateral palpebral raphe. So this was the orbital part. That was the orbital part. And now we are looking at the second one, that is called as the palpebral part. That is the palpebral part. If I write the attachment for you. So second part of this muscle, that is a palpebral. Origin this time from where? From the lateral part or the lateral portion of the medial palpebral ligament. That's the lateral portion. Insertion. This is not making a concentric ring. Upar wala upar ja, niche wala. So your upper lid and lower eyelid both are having this portion separately, and that is inserted to what? It is inserted to the lateral palpebral raphe. It is inserted to the lateral palpebral raphe. And this is basically responsible for the gentle closure of the eye because eyelid is present. It is not present outside the eyelid. It is present in the eyelid. So gentle. When you gently close your eyes like this, that is the action of this muscle here. When you tightly close the eye, then you need the orbicularis oculi outer part. That is orbital part also. So when it comes to action, the gentle closure of eyelid. Gentle closure of eyelid. So that's the second part, the palpebral part. Now third part, before I draw it for you, the third part is called as the lacrimal part. Because it has some function in relation to the lacrimal apparatus, so we call it the lacrimal part. This lacrimal part origin is basically from the lacrimal fascia. Is from the lacrimal fascia and lacrimal crest. I don't know if you remember it or not. I've shown you the lacrimal crest in the boundary of the orbit. We show there is a crest of the lacrimal bone called lacrimal crest. So it takes origin from the lacrimal fascia. Fascia is very important. Lacrimal fascia and lacrimal crest. This lacrimal fascia is forming the lacrimal sac only. The lacrimal sac that we have is basically made up of this lacrimal fascia itself. Insertion. It is running in the margin. It is running just in front of the tarsal plate. Tarsal plate is there in the upper and the lower iliac. So it is running in front of the tarsal plate, upper and the lower, and again goes toward the raphe. So insertion is same lateral palpebral raphe. But I'm telling you, it is present in front of the tarsal plate. Something like this. If I have just to use a different color to show it, use a red one here. So it is coming from the lacrimal, the sac over there. So it is coming from the lacrimal sac. That's the third part. This is the third part, and that is the lacrimal part. So we got the orbital part, we got the palpebral part, and we got the lacrimal part of this muscle. The lacrimal part, as I said, origin is not. Don't make sure the origin is not from the medial palpebral ligament. It is from the lacrimal crest and the lacrimal sac, which I've labeled behind over there. And insertion is same. Yes, the only thing is that palpebral part is more outside. It is more behind and above this the tarsal plate, and the one which is more in front of the tarsal plate is this lacrimal part. So what is the function here? The function here is when this muscle will contract. But when this muscle will contract, look at this red one muscle. When this red muscle will contract, it will pull the lacrimal sac. If it pulls the lacrimal sac will dilate. If the lacrimal sac will dilate, obviously there is a kind of a suction which is created inside, and that will suck the lacrimal fluid inside. So it is one of the mechanisms by which the lacrimal fluid or the tear are going inside the lacrimal sac. So this lacrimal part is responsible for dilatation of lacrimal sac, dilatation of lacrimal fluid, sucking in the lacrimal fluid. It sucks in the lacrimal fluid inside. So this is about one of the important muscle of facial expression which you got to remember. That is orbicularis. Okay, I would say even more important when the question is about just the attachment of the muscle. I would say this is probably the even more important than buccinator. अगर attachment वाला question है तो. If the question is more about the function and all, then obviously buccinator probably could be asked for. But I would rate both these questions more or less the same. So when it comes to the muscles of facial expression, ये दो muscle आपको नहीं छोड़नी. One is orbicularis oculi. About all the three parts, their origin, insertion, action. Make sure to draw the diagram. And that's how you're going to remember the attachments also and about the action. You know, it's easiest to fetch the answer marks in the muscle wale questions. If you know the attachments, origin, insertion, nerve supply, action, and you just draw one rough schematic diagram for any muscle, any XYZ muscle, if you just draw a schematic line diagram for this, you definitely will get your full marks. It's not that you have to write a clinical anatomy of every muscle, whether you know it or if you don't. But there are certain people who will just make 4 columns, write origin, insertion, nerve supply, action, and they will just end their answer there, which is also complete. But just drawing a very schematic or rough diagram always aids to your answer and help you fetch some extra marks. So, but coming to the second one, the muscle that we are going to discuss here is the buccinator. Okay. Again, buccinator is also having 3 fibers. We have upper fiber buccinator, we have lower fiber buccinator, and we have middle fiber buccinator, which are decusating also, which are crossing each other. So, how about if I just try to draw a schematic diagram for that? Let's say this here is the nose, upper lip, lower lip, chin. That's the mandible, and these are the mandibular teeth. This is maxilla, and let's say these are the maxillary teeth. I'll write the origin, insertion, everything in this in the diagram itself. So this obviously is the maxilla bone that you see above. Below we have a mandible. And if you remember, one of the origin of the superior constrictor muscle was a raphe called the pterygomandibular raphe. Somewhere from the pterygoid plate to the mandible, a raphe is coming. That is called the pterygomandibular raphe. So there is a raphe which comes and attaches to the mandible. So these are some particular reason I wanted to discuss all these muscles later with you. Because you already, if you have revised the pharynx part, then you must be knowing what is pterygomandibular raphe. It is a major origin of the superior constrictor muscle. पीछे की साइड में सिर्फ superior constrictor muscle originate होगा, आगे की साइड में buccinator muscle. So we have superior going backward. Superior constrictor going backward and buccinator muscle which is going in front from this raphe. But as I said, the buccinator muscle is having 3 fibers: upper fiber, lower fiber, and middle fiber. See, upper fiber will take origin from the maxilla, lower fiber will take origin from the mandible, and middle fiber will take origin from the pterygomandibular raphe, which is quite clear from this picture itself. From where? Opposite molar teeth. Upper fiber will take origin from the where? From the maxilla, opposite to the molar teeth, and will go like this. I'll write that for you. Lower fiber will take origin from the mandible, opposite molar tooth, and will go to the lower lip. Obviously, one is going toward the upper lip, one is going toward the lower lip. That is upper and lower fiber. And the important thing is with the middle fiber. Middle fibers are taking origin from pterygomandibular raphe, and they are crossing. So it's like middle fibers are originating like this. So the fibers which are originating above are going toward the lower lip, and the fibers which are originating below are going toward the upper lip. And this is the area which is pierced by the parotid duct also. Actually, parotid duct middle fiber going cross over. Let's write in the diagram itself. This here, these are the upper fibers of buccinator. And I said upper fiber, where they are originating from maxilla, opposite to molars. These are lower fibers. Lower fibers are originating from mandible. Same story. Opposite to molars, all 3. Middle fiber, obviously. Middle fibers, they are originating from this. I want to write this whole thing here. That is pterygomandibular raphe. And the important thing is that middle fibers, they decussate. The one which are starting above goes to the lower lip, and the one which starts goes to the upper lip. So simple is that middle fibers they decussate. middle fiber of decussate, and then decussating middle fibers are the ones which are also pierced by the parotid duct. When you look at the picture, if you just pick up any atlas, look at the picture, which is when the parotid duct is piercing buccinator muscle, you know that it is piercing this for the most, the middle fibers which are decussated. So in this picture only you have origin, you got an insertion, you have three type of fiber, upper, middle, lower fiber, and the origin insertion. Nerve supply is, it's all facial nerve, you know, that's obviously orbicularis, oculi, or whether it is muscle, all the muscle of facial expression are by facial nerve. I don't have to tell you that, you already know this. Action. What is the action of this one? First, this helps to flatten your cheek against the gum, like this. If I do like this, flattening of my cheek against the gums, it is done by this muscle. But there's another function which is exactly opposite, blowing of the cheek out like. This is also done by buccinator. So buccinator muscle, basically, it can help the cheek to go inside, get them flattened, or it can also help in the, what do you say, the blowing out of the cheek, like in whistling. Also, this buccinator muscle, when you I told you this in the facial nerve also, the buccinator muscle which is working on the cheek, it can create the space between the gums and the cheek. When this muscle is helping to blow the cheek out, the buccinator muscle, so what will happen? My tongue will get the space to run like this. And I can use my tongue to clean the food from the vestibule. So that means the space which is created between the vestibule and the cheek is also one of the functions of the buccinator muscle. So when it comes to buccinator, one of the functions is flattening of cheeks against gums. Flattening of cheek against the gums. It prevents what? Food accumulation. It prevents food accumulation in vestibule. When vestibule word बहुत use होता है, this vestibule here is basically the space between the cheek and the teeth. Teeth or gums, you can say that space is the vestibule only. And this also is called as the whistling muscle. So this muscle also helps in the whistling. When you whistle, all this. So obviously you're flattening the cheek and you're blowing the air out, so that is whistling. So all these are the functions of the buccinator muscle. Right? So make sure that you add these two muscles to your notes, the buccinator and the orbicularis oculi, about their detailed attachment and their action. And if possible, as I always say, draw one schematic rough line diagram if you don't have enough time. Just draw a rough diagram, line diagram here to show how exactly fibers are moving. So guys, the next topic that we're going to discuss today is something related to muscle that we just discussed, and that is the lacrimal apparatus. Lacrimal apparatus, I told you that eyeball, we'll be discussing eyeball, and internally we'll be talking about a certain part of it in the neuroanatomy. But lacrimal apparatus, let's finish off with the head and neck only, because we'll not get the chance to do it in the general. When I say lacrimal apparatus, it's not only the lacrimal gland, there are many parts to it. So guys, lacrimal apparatus, this lacrimal apparatus is usually a short note question, but I have seen sometime when, I've seen, although very few times, that this may come as a long question also. Although it doesn't deserve to be asked as a long question, but because of the nerve supply on especially, and you already know that secretomotor pathway of lacrimal gland and sympathetic pathway, which I'll discuss it again. For that reason, it can be asked as a long question, because nowadays, in fact, from last many years, the long questions are very fragmented. You already know that what is to be written there. They will tell you, describe the lacrimal gland under the following headings, about the parts, about the innervation, about the clinical anatomy, maybe like that. So for that reason, it could be a long question also. Generally, as a short note question, the lacrimal apparatus. When it is a short note questions, explain about the lacrimal gland, tell about the parts, don't write anything about the part, and make sure you pay attention to the innervation portion of the lacrimal gland. Okay. So I'm going to talk about the entire lacrimal apparatus. But lacrimal apparatus, when you say what it includes of lacrimal gland. Lacrimal glands are obviously having the ducts, so these are lacrimal ducts. These lacrimal ducts they pour the tear, the lacrimal fluid of the tear into the sac, which is called as a conjunctival sac. Conjunctival sac. I hope you know what is a conjunctival sac. You know the conjunctiva is the outer covering, guys. So we have two types of conjunctiva. One is which is covering the eyeball. We call it a bulbar conjunctiva. Or एक जो अंदर से eyelid को cover कर रहा है. Imagine this is the eyeball here, and here is the eyelid which is covering it here. So conjunctival covering which is covering the eyeball, that is called as the bulbar conjunctiva. And the same bulbar conjunctiva will continue on the inner surface of the eyelid. That is called as the palpebral conjunctiva. So ये पूरा एक sac बनेगा between the eyelids and the eyeball. The space inside is called as a conjunctival sac. It's a conjunctival sac. From this conjunctival sac, the tear will go toward the side. There is an opening over there called as a lacrimal. I will show it to you. Called as lacrimal punctum. There are two lacrimal punctum, ऊपर एक नीचे. And these lacrimal punctum are basically draining the lacrimal fluid by lacrimal canaliculi. Lacrimal canaliculi. Into what? Into the lacrimal sac. Remember the lacrimal sac, which was also giving origin to the part of the orbicularis, ocular muscle, lacrimal sac. And from the lacrimal sac, finally, the tear, or you can say the lacrimal fluid will go into the duct called as a nasolacrimal duct. So these are the 7 parts of the lacrimal apparatus. If I talk about the entire apparatus, we've got the lacrimal gland, ducts, conjunctival sac, then canaliculi, we have punctum, canaliculi, sac, and then nasolacrimal duct. How about we just draw this diagram first? It will be easy for us to discuss the rest of the things. So let's take an example of one side eye. Here we got, this is the, let's go nice and easy here. The muscle, one of the muscle which is responsible for elevating the eyelid is called as the levator palpebrae superioris. Right? You know this muscle, levator palpebrae superioris, one of the muscles supplied by the Edinger-Westphal nucleus 2/3 nerve. This muscle here is LPS, levator palpebrae superioris. You know about this, right? This levator palpebrae superioris muscle is going to divide the lacrimal gland in 2 parts. One part which is in relation to the bone, we call it the orbital part, and one part which is in relation to the upper eyelid, we call it a palpebral part. So there are 2 parts of lacrimal gland, and that is divided by, or you can say the gland is J-shaped gland. It is winding around this LPS muscle. Outer part of the orbital part is large, and palpebral part is small. So this larger part, let me just write it here. This is called as the orbital part. It is in direct relation to the bone. I'll tell you which one is that. And this portion of the gland is the palpebral part, which is present in the upper eyelid. So first thing first, the lacrimal gland is basically it is divided in two parts, orbital part and palpebral part, and that is done by the muscle, that is LPS muscle. It winds around the LPS muscle. That's how it is done. We got some ducts. We have a ducts coming from the deep part. Orbital part is the deep part. So we have some ducts coming from the deep part directly, an opening like this, and then we have numerous ducts which are coming from the superficial part or the palpebral part. And ultimately, the tear will come into this sac. I told you that sac over there is what conjunctival sac here. These are the lacrimal ducts. These are the lacrimal ducts. I'll tell you about these lacrimal ducts here. Many lacrimal ducts, like, there could be 12, 13, maybe 14 lacrimal ducts could be there, and they go into this sac which is called as the conjunctival sac. So thin film of lacrimal fluid is spread on the entire eyeball, and then obviously this tear moves toward the medial side, and here we have opening which is called as a punctum. The next thing that we said after conjunctival sac is lacrimal punctum. Lacrimal punctum is an opening which is leading to the canaliculi, and this lacrimal canaliculi is having a vertical part and the horizontal part. Vertical and horizontal part. And this vertical and horizontal part, they are ultimately going to open into, these are canaliculi, and they are opening into the lacrimal sac, and then this lacrimal sac is continuing downward as the nasolacrimal duct, which is having a valve also. So this label represents for this thing here is what? That is a punctum, that is lacrimal punctum. This here is the lacrimal canaliculi. This is lacrimal sac, the same lacrimal sac which was present behind what ligament? Medial palpebral ligament. And this is a nasolacrimal duct. That's a nasolacrimal duct, which is also having a valve in the lower part. I'll show you. I'll discuss it. So that's how the entire apparatus is present, guys. The part of the apparatus: lacrimal gland, ducts, conjunctival sac, lacrimal punctum, lacrimal canaliculi, lacrimal sac, and nasolacrimal duct. Take part to the Now come to the different parts. Let me first talk something about the lacrimal gland, and then we'll talk a little detail about all these canaliculi, lacrimal sac, dimensions now. The main thing is the lacrimal gland that we're going to discuss here first. The lacrimal gland, we said first of all, this lacrimal gland, it is a J-shaped gland. Few things that we need to write here. That's a J-shaped gland, and it's a serous gland. Basically, it's a serous gland. You have serous secretions in there. So I'm just telling you some important points to be written over there. And around LPS, this gland is divided in two parts. Around LPS, the gland is divided in two parts. One, we have the larger part, the large part and the small part. The large part is the orbital part. The large part is the orbital part, and the smaller one is the palpebral part. Location, where the orbital part is present. The orbital part is present, if you remember the orbit, the discussion that we had in the orbit, in the roof, anterolaterally. In the roof, anterolaterally, somewhere here. There is a fossa over there, and that fossa is called the lacrimal fossa. Please do not confuse between lacrimal fossa with lacrimal fascia or the lacrimal sac. Lacrimal sac, medial side there. Lacrimal fossa is in the roof toward the anterolateral side, here. So this orbital part or the larger part, it is present in lacrimal what? In lacrimal is present in the lacrimal fossa. And this lacrimal fossa is present where? In the anterolateral part, of course. And where is the palpebral part? Palpebral part is present in lateral part of upper eyelid. Lateral part of upper eyelid, we got this palpebral part present. Right. That's about the gland. Lacrimal gland, then we said it is having ducts, the lacrimal ducts are there. Now overall, there are approximately, if I go with the numbers which are quoted in the book, there usually say there are 12 ducts are there in it. Out of those 12 ducts, around 4 to 5 ducts are coming from where? From orbital part. Deep parts directly are into the conjunctival sac. From the orbital part, we have 4 to 5 ducts, and the remaining, the larger number of ducts, that is 6 to 8 ducts, they are coming from the palpebral part. The palpebral part. And there's an important clinical anatomy regarding this, which I'll tell you at the end. And telling about the lacrimal secretion here, almost around 1 milliliter of lacrimal fluid is produced, but 1 ml lacrimal fluid or 1